A very good morning to all of you. We have come to the day 2 of the International Health Conference of Inquirer 2014, Trauma and Emergency Care. So I warmly welcome you once again to day 2 of the conference. Before I start, I would like to kindly request something from the audience. Please be kind enough to switch off your mobile phones. If you want to answer a call, please go out of the auditorium and answer the call because we had many disturbances yesterday. Thank you. To start today's conference, I cordially invite Mr. Tim Morse from Coventry University, UK, to do the keynote address.
Good morning. Thank you very much for asking me to deliver this shorter talk, I hope. When I was sort of thinking about what I was going to say this morning, I thought it would be certainly an opportunity to think about what we did yesterday and to think about really looking at the fact that we are actually picking out some sort of global standards relating to managing trauma and indeed emergency care. So what I wanted to sort of pose to you really, and this is certainly to more so to the nurses and students out there, is that have you ever thought that within Sri Lanka, how you might be able to change emergency care delivery, or indeed care generally? Is there anything that you could have done or can do to evoke change? Now, whatever your career pathway is intended, we've all got a common goal, and that common goal is looking after our patients and either promoting their health or indeed promoting them to a comfortable death, perhaps. So, in terms of trauma care and emergency care, what can you do to change it? Just to have a think, perhaps, as to what you could, how could you influence things? Have you ever dreamed of changing something? Well, we all know that working in healthcare is about caring, funnily enough, and one of the problems that we experienced in the United Kingdom in 2005-2009 was that it was noticed by various audit organisations that the number of patients within Mid Staffordshire Hospital, there was an unexpected number of deaths. The number of deaths seemed to be increasing. So there's an investigation. And the investigation actually showed up the fact that it was to do with staffing levels was probably one of the key features. The other main feature, though, was the changing in attitude because of the stress and the difficulties the nurses were finding working in an environment that was particularly understaffed. Everyone's got a role to play in the healthcare system, and everybody's role is there to safeguard the quality of patient care. And it was clear there were areas within the delivery of that care where there seemed to be some void or some lack of care delivery. In fact, one of the things that has developed from this is how we recruit nurses for the future. And certainly within the UK now, we're not only looking at potential student nurses who are qualified and have the required qualifications, but also that they demonstrate quite early on that they do actually have a caring attitude towards patients. And that's quite hard to tease out when you're interviewing people. So what happened as a result of the inquiry came this report, which was done by Dr. Francis, and hence the Francis report. The Francis report finally was published in February 2013, so quite a recent publication, but it highlighted a couple of things. The first thing it highlighted was around the element of care. So the Department of Health in England launched something that we call the 6 C's. So what are the 6 C's? Well, we'll talk about that in just a couple of moments. The intention of these 6 C's, and indeed the Francis report, was to actually have a fresh look at delivering future care. How can we deliver future care that's high quality, indeed caring, but within the financial constraints that the world seems to be facing? And in fact, the issue around caring actually now works from top down, and certainly in terms of accountability, the managers now have accountability whereby if for some reason there is any changes in staffing, they're being short, or indeed the death rate, which goes as unexpected, then they are held account to answer now, and indeed can be dismissed because of it. So it's affected everybody. So what are these 6 C's then? Well, 6 C's published by the Department of Health, our National Health Service, are care, compassion, competence, communication, courage, and commitment. But what are these? What does it mean when we're trying to change and reintroduce the culture of compassionate care? Well, care is your core business, it's my core business. That's what we're here for. That's what we're here for in terms of all of our organisations. The care that we deliver has got to help somebody. It's got to assist them to either get better or indeed eventually maybe or death. It should improve the community health. Okay, so we should be concerned about promoting health across all communities and making sure that everybody benefits. And the people receiving the care should expect it to be consistent. The care that they receive in the north of the country should be the same care that they receive in the south. And it should be consistent throughout their life as well. So it shouldn't be just focusing on one particular age group. It should be consistent throughout, whoever you are or wherever you are. Then there's this issue of compassion. What's compassion? Well, compassion is how care is actually given, and it's through different relationships, and it is based on empathy. It is based on offering respect and also maintaining the individual's dignity. Dignity not just for the patient, but their families and carers too. Now, it's also described, and so the Department of Health describe it, as intelligent kindness. And that's to do with how people perceive their care. So the attitudes of how you respond to when people visit a ward, for example. And there are occasions where I've gone onto a ward and I've been totally ignored. Nobody said good morning or good afternoon, and that needs to come back. What about competence, though? Because we need to measure and maintain competence. Okay, so we do need to make sure that all of those within a caring role have the ability to understand the individual's health needs and social needs and know how to deliver it. So they have to be competent practitioners. So it is about expertise. It is about having both clinical and technical knowledge, but also making sure that the care we deliver is based on the best evidence, not based on this is how we've always done it. Communication, and in fact, within the UK, the Nursing and Midwifery Council now say one of the biggest reasons as to why nurses are struck off the nurse register, it's because of poor communication either between nurses and other healthcare workers or between nurses and patients. That's concerning because the number of inquiries from the Nursing and Midwifery Council against nurses has quadrupled in the last 5 years. It's a significant number of investigations now against nurses for whatever reason. So it's central, isn't it, to what we do. We need it for good team working. When we're going to work as a team, we've all got to communicate together. Listening, clearly, is important. As to what we either say or what we do. So as well as asking people or talking to people, we've got to listen to people as well. We've got to listen to our patients, what they want. I think it's essential that we have this phrase, no decision about me without me. In other words, if I'm going to be involved in a decision, then I need to offer my opinion. I need to speak up. It's key, isn't it, to a good workplace, making sure that if we all communicate, we all know what we're doing, it does help with morale within the teams. And it helps you as staff. What about courage? This is to do with if you feel strongly enough about something that you actually stand up and speak out as to what you believe. Not only about concerns, but also about the things that are good as well. It's doing the right thing for people. And that's to do with your own personal strengths. Possibly having a vision as to how we're going to innovate and embrace different ways of working. How can we do things differently that might make things a little easier, but actually benefit everybody? We've got to be committed. I do know a number of nurses where they'll turn up for work, for a shift, and they go home at the end of that shift. And if I was to ask, for example, do you mind staying just a few minutes longer because we're really busy, but tomorrow we can go off early, they would insist on leaving on the dot, whatever they were doing. And it is about being committed to our patients and the populations within which we work. We need to build on our commitment to improve not only care, but to improve the experience as well. Okay, we want to treat them as we would treat our families. We need to take action, and we need to make this vision. We need to turn it into a reality. So if we've got any other challenges ahead, we can actually tackle them and face them and sort of develop what we may seek for our future. But they've missed a trick. Department of Health published those 6 C's. Should it be 7? It's a dream, perhaps, to have that 7th one, 7th C. What could it be? The important thing for me, I think, is striving forward to develop a dedicated and high-quality service. That's what we want. That's what we all want. Collaboration is the 7th C, missing there. It's collaborating not only with each other, but also across the world, grasping global standards that work. It's about working in partnership and sharing experiences. So let's bring it back now to trauma and emergency care. I suggest that you only settle for the best. That can only be the standard. We need to seek global standards, and we saw that yesterday through us all singing, really, from the same hymn sheet. Wherever we came from as a country, we were all talking about the same way of either assessing or managing problems. The Department of Health said that they intend to have the right staff, so with the right people for the job, with the right skills, in the right place. But obviously at the right time as well. Got to be there when they're needed. And that is certainly something that again changed across the UK by now offering 24-hour investigation support. Certainly a number of years ago they used to say, sorry, you can't have your x-ray tonight because there's nobody working, come back tomorrow. That doesn't happen anymore. It's 24-hour, 7 days a week. It's always possible, though. Well, let's just think about the International Institute of Health Sciences. And these are indeed some of my opinions and beliefs. The Institute's grown, in my mind, incredibly. It's been a huge growth in such a short time. An awful lot has been achieved. They've become affiliated with many, many organisations, many to which I didn't appreciate. So, what is collaboration then? Well, it's to succeed through reaching out with common objectives. And we've all got common goals. So it is about sharing ideas and having that common deep determination that we can all achieve. We all can actually do this. So who's collaboration for? Well, it's for you. It's for your patients. It's for your families. The future's with you. Thank you very much.
Thank you, Mr. Tim. So let's enjoy a cup of tea for 15 minutes and come back to the auditorium. Thank you. Please be seated quickly. A kind reminder once again before we start the conference, please switch off your mobile phones. The first speaker for the day is Dr. Leonard Ranasinghe, the clinical professor, California North State University College of Medicine. So I would like to invite Dr. Ranasinghe to talk on the topic, Emergency Management of Head Injury, Issues and Development. Over to you, sir.
Thank you, Nishani. Good morning. Hope everybody had a good rest last night. Before I start my lecture, I want to mention one point Mr. Morse mentioned, which really, struck me very clearly. I think it's something all of you probably should be thinking about and apply in your practice. As medical providers, all of us who are gathered here have some connection to medical practice. Some of us are direct medical providers, some of our teachers. So regardless, we have some connection to medical practice. So when you see patients, think always you treat that patient as if it is somebody you love, somebody you care. So it could be your mother, your father, your brother, whoever. Think of that patient as that, because that will give you an opportunity to be empathetic and caring. So think about it. So we'll talk about head injury. Approximately 500,000, which is about 500,000 head injury cases in the United States every year. The interesting thing about head injury is because majority of the patients who sustain injuries, majority of the severe head injury patients do not make it to the hospital because they have usually associated atlanto-occipital separation, or they have high spinal cord injuries, which will lead to apnea, and sometimes they have multiple organ injuries. So they don't really make it to the hospital. But fortunately, I should say, 75% of the patients we see with head injury, they are minor. They are not that serious, but always concerning, though. You still have to do your complete evaluation to make sure that you don't miss anything. And 15% is what we call moderate, and 10% severe head injuries. So I just want to briefly give you a background on anatomy, because this is relevant when we talk about head injuries. So the head, if you think about, start with the scalp. The importance of scalp, because scalp has very generous blood supply. And this is really important in children because, when children bleed, even a small amount of blood loss compared to us can be significant. So always think about that blood loss. And even in adults, if there's continuous blood loss, it can be serious. And in fact, I had a patient who we had a very difficult time to control bleeding, and he was profusely bleeding. And by the time we got this was an adult who was not, in fact, not an anticoagulant, and he was just a regular, about like 20 or 30-year-old male patient. And by the time we controlled and we monitored him, his hemoglobin level had, in fact, dropped significantly, and we had to admit that patient. So even though we see as minor things on the scalp, think about possible significant blood loss. The skull, think about the skull, there's cranial vault and the base. The base is irregular. So when you have an acceleration or deceleration injury, the brain kind of slides forward and backwards. So if you have a rough surface at the bottom, brain is going to slide on that rough surface forward and backwards in acceleration and deceleration. You can expect that, you see, it can cause confusion. So just like if your arm, rubs against a metal something or something solid, it can cause bruises and contusions. The same thing which can happen on the brain. Those contusions may not be simple. They could be significant. We'll talk about that later. The other thing about the cranial vault is that the cranial vault, has anterior fossa, middle fossa, and the posterior fossa. And in the temporal area, the bone is usually very thin, and the temporal artery, especially the middle meningeal artery, it goes right underneath that one, and that is significant. We'll talk about that a little later. So temporal bone, middle meningeal artery, and any injury to the temporal side, always think about some serious injuries. And I've had several patients who have had significant problems. Now, what about the meninges? Meninges are just the coverings on the brain, and it starts right underneath the skull with the dura membrane. You've heard of the dura membrane. It is a thick, fibrous membrane which firmly adheres to the inner surface of the skull. So essentially, there is no space there between the skull, inside of the skull, and the dural membrane. However, in certain areas inside the skull, this dura kind of splits into two, like a little pockets-like things, where the venous blood is drained into. Those are called venous sinuses, and that's significant. So we'll talk about that a little bit later, why these spaces are important. Right underneath that is the arachnoid membrane, and the arachnoid membrane is a thin paper-like membrane, and there's a potential space between the dura and the arachnoid membrane. Now, again, that's significant because of the dural, bleeding between the dura and the arachnoid membrane, which we call the subdural bleeding. Then underneath that is the pia membrane or pia mera, which is almost firmly attached to the surface of the brain. And the cerebrospinal fluid, CSF, is in that space between the pia membrane and the arachnoid membrane. And that is important because the CSF, cerebrospinal fluid, is the cushion for the brain as well as the spinal cord. And if there's bleeding in that space, subarachnoid space as we call it, between these two layers, and that blood is significant because when there's blood there, CSF cannot be reabsorbed. CSF is constantly recirculated. It's made and it's recirculated throughout the brain as well as the spinal cord. But if blood is there, the arachnoid villi, which are the reabsorbing parts of the brain, cannot reabsorb them. So what happens? Then the blood stays in there because blood's not getting, the CSF is not getting reabsorbed. The pressure increases, which can cause significant problems in the brain. So here's a structure. Unfortunately, I don't have a pointer to mention, and you may get this in your CD later on, this picture, but the membranes are marked in this one. So, brain has three main parts, most I think you all know, and I'm only going to talk about it from the point of your head injury. The cerebrum, the cerebellum, and the brain stem. We all know about the cerebrum, which are the frontal lobe, the middle lobe, and things like that. And there are certain areas in the brain which are significant. So depending on where the injuries has occurred, their clinical presentation may be different. The brain stem has the midbrain, the pons, and the medulla. Now, why is this important? This is a very sensitive area of the brain. The midbrain and the upper pons contains what we call the reticular activating system, RAS. The reticular activating system is the one which keeps us awake. So if there's a significant injury to this area, the patient may be comatose, unresponsive, because the reticular activating system has been affected. So when a patient comes with a head injury in comatose condition, this is one of the reasons, not the only reason. And then the medulla. Why is the medulla important? Because it has vital cardiorespiratory centers. Cardiorespiratory centers. So if anything happens to this area, their respirations get erratic, blood pressure can go out of control, and things like that happen. Uh, the other thing about this is unfortunately sometimes CT scans may not pick up injuries to this area clearly initially. And sometimes, you may need an MRI scan, but of course, you see that's a different thing which you have to do at a different time. Here's another important thing about the brain. Now, there are two compartments in the brain. It's called the supratentorial and the infratentorial. The supratentorial part, this is separated by a membrane called the tentorial notch. And that's where the midbrain goes through. And the oculomotor nerve goes right at the edge of that. So why is this important? Oculomotor nerve is the third nerve. Right there, you see on the oculomotor nerve, or the third nerve, outer surface of that has the parasympathetic fibers. So parasympathetic fibers, as you know, causes the pupils to constrict. Sympathetic fibers cause the pupils to dilate. So those two work opposite. So if the brain is getting herniated and cause compression in that area, the third nerve gets compressed. The parasympathetic fibers, which are now in the outer surface of that, get compressed. So what do you see? Pupil gets dilated. So if a patient has one eye with a dilated pupil, the reason is that most likely the patient is herniating. So this is why this anatomy is helpful for you to know. The other important thing about this is right where this tentorial notch is where the midbrain goes through. Midbrain also has what we call the pyramidal tract or the corticospinal tract, which is the motor fibers. And right there, it crosses to the opposite side. So when there's compression again in the midbrain, if the brain is herniating, midbrain is getting compressed, and what happens? The motor fibers, the tract, gets compressed. So because it's crossed over to the opposite side, you'll see if the bleeding is on the left side, your left pupil is dilated, but your right side is paralyzed. Or, beginning to get, at least in the beginning stages, maybe getting weaker, but eventually can get paralyzed. So that's why you say ipsilateral dilated pupil and contralateral paralysis indicates usually herniation. So that's what you need to suspect and start thinking about. So anatomy is important from that point of view. Ipsilateral means same side, contralateral means the opposite side. So a little bit of physiology as well. With intracranial pressure is very, very, very important. And usually the intracranial pressure is maintained at about 10 millimeters of mercury. If it goes more than 20, that means it's a bad sign. And obviously we can't measure that in the emergency department, but the neurosurgeons, can measure that with the special instruments. So anytime there's a head injury, the intracranial pressure go up. So elevated intracranial pressure not only may indicate that there's a presence of a problem, but it also contributes to that problem. So it kind of goes into a vicious cycle after that. So we'll talk about, what we should do about that. So higher the intracranial pressure with the head injury, the worst is that outcome. So our objective should be to do whatever we can to reduce that intracranial pressure. What is Monroe-Kelly doctrine? Monroe-Kelly doctrine essentially mentions that brain is a fixed volume compartment. It's kind of obvious. It's like if you take a soccer ball, for example, once it's inflated to the maximum, that's all you can inflate. But if in the case of the brain, if you get a bleeding in the brain, now there's a third part. You see, you have the CSF, you have the brain tissue, you have the venous blood, you have the arterial blood. Now there's a fifth element now bleeding outside all those areas. So when there's an extra volume in the brain cannot expand because of the skull, and something has to give in. So initially, what happens is there's a certain amount of CSF and the venous blood will be kind of pushed out to maintain the intracranial pressure at a reasonable level. But it can only do to a certain level. As soon as it reaches that critical point, immediately then the intracranial pressure shoots up within minutes to a few hours. So our objective is again not to let that happen. So what is really important is not to allow the patient to get hypotensive because it can cause a severe secondary brain injury. Cerebral blood flow, we have to maintain adequate cerebral blood flow so that the patient will not sustain secondary brain injury. Primary injury is direct injury. Secondary injury is when the patient becomes either hypotensive due to hypovolemia, patient gets hypoxic, means not enough oxygen, and sometimes you see the carbon dioxide level, PCO2, can be different. If it is too low, it can cause vasoconstriction, and vasoconstriction causes cerebral ischemia. And if the PCO2 is too high, it causes vasodilation, which can cause edema of the brain. So it is not easy to balance this. So you have to be very careful. So in these patients, we monitor their PCO2 levels very, very carefully. So in those patients, not only the oxygen has to be measured, but you have to also monitor the PCO2 levels. So the primary object, like I said, is to reduce the secondary brain injury. And if you remember that, in brain head injury, prevent secondary brain injury, that covers the entire lecture. And you can leave now. So that's the bottom line. Always remember, prevent secondary brain injury. But since you are here, I'll talk a little bit more. How do you classify head injuries? You can classify by mechanism, severity, and morphology. And mechanism, it could be the blunt trauma or penetrating trauma, which is kind of straightforward, and you can understand that. And under blunt and penetrating trauma, you also get skull fractures. The skull fractures are classified as linear skull fractures or stellate, or depressed or open skull fractures. Under and the severity of injury, we use the Glasgow Coma Scale. And I'm sure most of you have seen DSF, right, in your books and studied the GCS. Yes? No? Okay. But if you want to quickly go through, remember there are 3 elements you have to check: the eye opening, verbal response, and best motor response. And I'm not going to go into detail, but the score is given according to that, as you can see. So when you get a chance, review that, because this is something you have to document as a nurse, as a physician. And this must be documented, because when the patient comes in, the GCS level may be 15, meaning completely normal. But an hour later, GCS could be 9. So that means, you see, if you had documented at the beginning what the GCS level, then you know that the patient has deteriorated. So you have to do something about it. And when you document GCS score, I have seen, in fact, some of the junior doctors documenting GCS score 12. And I look at it and say, what does it mean? It doesn't mean much to me, I said. You have to give each category E, I, how many, B, how many, because that way we can get an idea what each element was at the beginning. A total score alone is not enough. So always specify the eye-opening score, verbal response score, and the best motor response score. So if you want to classify this head injuries according to the severity, then you need to think about that GCS of 13 to actually it's not 14, it's 15. So GCS 13 to 15 is mild brain injury, and that's what we said about 75% of the people we see in the emergency department. Between 9 and 12 is moderate injury, and 8 or less is considered severe. So coma, a patient has a GCS of 8 is almost always is in coma. And those patients we always intubate. In fact, personally, I intubate if GCS score is 9 because I expect that somebody that low, you expect the patient to go further. As a precaution, I would do that. That's my personal choice. But the recommendation is that a GCS of 8, you have to intubate that patient and connect to a ventilator to protect the airway and things like that. So we talked about skull injuries. I got some pictures. Now remember, skull fractures, don't confuse with the natural sutures skull has. So this is a suture line actually. And these are suture lines what you see. And they are not fracture lines. Now middle and meningeal artery, you can see it's going on the groove on the temporal bone area right there. And the left picture and right picture. And if there's a fracture, you see that artery will get lacerated and the bleeding will occur in the epidural area. Well, we'll talk about it. I also already mentioned about the skull fractures, the linear fractures, depressed and opening, and the open fractures. They are significant because depressed and open fractures, that may have a communication between the brain, CSF fluid may be leaking, and those patients have to be extremely carefully managed, and neurosurgeons must be notified. And remember, even if you see a simple skull fracture, it takes a lot of force to cause a skull fracture. So, that patient has sustained significant head injury. Sometimes these patients do well, but at least you have to think about it and observe these patients carefully. The estimate is that if there's a skull fracture, there's 400 times more risk for them to have an intracranial injury. So here are some skull fractures. Here's a linear fracture, two linear fractures, and here's a depressed fracture, which of course you cannot really say on the picture, but if you palpate this patient's fracture area, you can feel the bone dipping. Of course, you have to wear sterile gloves to do that. And this diastatic fracture means that fracture goes along the suture lines, so they kind of sutures separate, opening the skull a little bit more. So the other way is according to the morphology, and so brain injuries, so you can divide as focal, diffuse, and secondary. In the focal brain lesions, we have the epidural injuries, or epidural hematomas, subdural hematomas, and intracerebral hematomas. Diffuse brain injuries, it can be mild or it could be severe. In mild cases, you may have a completely normal CT scan, and patient may be completely normal. They may have a history of, some loss of consciousness or something like that. But in the case of diffuse brain injuries, what happens is, when you look at the CT scan, you don't see bleeding or anything, but you will see some abnormalities, and I'm going to show you in a little bit. So epidural hematomas, they are located outside the dura. Now remember the membranes I mentioned? Right underneath the skull is the dural membrane. And remember I said the spaces are open in certain areas. There are, the middle meningeal artery goes on this side especially, and this is the most common, although it can be caused by venous bleeding as well. But most commonly, it's a fracture of the temporal bone causing the laceration of the middle meningeal artery. And that bleeding is now between the dura and the skull. That's why you call epidural. Epi means outside. So epidural. And they're not that common. They're about only 0.5%. But, about 10% of those people can go into severe, problems. I had a patient once, a motorcycle rider. This was long before CT scans were available in every hospital in the U.S. I was working in Ohio at the time, and CT scan was in the other state in Indiana. So we had to send the patient by helicopter if we wanted to get a CT scan. So the patient was completely alert and oriented, and I talked to the admitting doctor. I said, let's observe the patient in the ICU. And about 4 hours later, that patient started dilating his pupil. It started becoming more somnolent, and fortunately we were able to fly him out immediately to the other hospital. The CT scan, he had epidural hematoma, and he did okay. But these patients will, what we call, talk and die, because they come, they have a lucid interval, but they can deteriorate quickly, and so you have to be careful. The thing about, now here's an epidural hematoma. When you look at it, you see the shape of it? It's like the shape of a lens. And the reason is because, this bleeding does not cross the suture lines. So it just, only that area, it just gets puffed up because dura gets just pushed towards the brain. But if it is not corrected, if the bleeding continues, it keeps pushing the brain. As you can see, the ventricles, so those black things in the upper part, those are the ventricles. See how the one ventricle on that side is completely now pushed in, and the midline, if you look at it, has been pushed in as well. So, subdural hematoma. This is more common than epidural hematomas, but it has a high mortality. Now, some people do okay, and this is more common among older patients. The reason is because, there are what we call bridging veins from the surface of the brain going into those venous sinuses. And those bridging veins, here, of course, they are microscopic in a way, but at the same time, they are significant. What happens when we get older? I'm not talking about myself now, okay? So, I'm talking about, you see, somebody who's, but anyway, as you get older, what happens to the brain shrinks a little bit, so if you look at my brain, it might be shrunk a little bit. So my wife tells me that sometimes. So when that happens, you see, when the brain shrinks a little bit, those veins get a little bit more stretched. So they become more, susceptible, vulnerable to get, injured easily, lacerated easily, break easily. So when you have that kind of a problem, and those will bleed, and that will cause the subdural hematoma. So subdural hematomas, that's why in older people, when they have a head injury, we are very careful. We almost always get a CT scan. And and also remember, older people, in addition, may be on aspirin, maybe on warfarin or some other anticoagulant. So they are more susceptible. So, but subdural hematomas are also can occur in other people, not only older people. So early diagnosis is extremely essential. Now, the subdural hematomas can be classified into three groups as acute, which is less than 3 days, subacute, which is 3 days to 3 weeks, and chronic, which could be after 3 weeks. I had a patient, African American, we don't call blacks anymore, he's an African American person, and he came when I was working in Washington, D.C. area. He's a very interesting guy. He just walked in. I still remember this man. And he said, I hear music. We all thought he had a little psychiatric problem. I asked him what kind of music. And he said, country music. I don't know if you know what country music is in the U.S. It's a kind of a special type of music. And then he said, I even don't like country music. So I started thinking, this is strange. But just, I went back, and after a while, I went back and I talked to him, did you have a head injury any time? And he said, yeah, about 3 months back, I was walking under a staircase in the apartment building he was living in. I said, I struck my head on the, staircase. And he was about 55 years old, but he was an alcoholic also. So they are more susceptible to these things. You see, their brains also shrink a little bit, even younger than, our older people. Older people like me. So, got a CT scan, he had a subdural hematoma. And that's a chronic subdural hematoma. Fortunately, he did not have a serious issue, but for the rest of his life, he'll have to listen to country music. Now, here's a subdural hematoma. Now, if you recall the one I showed earlier and this one, you see a difference, right? This is not lens-shaped. The blood, this is the white part, by the way. And this is you see the white part on the left-hand side of the picture? And that's spread, kind of thin all the way down. And it goes all the way down because it can cross the suture lines. So it can spread all the way down. But it can also cause the pressure, and that's why you see the ventricles, those black things in the middle, have been pushed to the right. And if you look at the midline from the top, and see the midline has been shifted as well. So this patient has significant brain injury. Here's a subarachnoid hemorrhage, which happens underneath the arachnoid membrane, between the arachnoid membrane and the pia mater. And here's a bleeding inside the ventricle. It's significant bleeding inside the ventricle. Sometimes this happens not only due to trauma, when there's uncontrolled hypertension, it can bleed on the side of the ventricle, but they can get into the ventricles as well. So, contusions. These are fairly common. And they can be associated with subdural hematomas or even epidural hematomas because of the head injury. And when there's a contusion, what happens is you have a head injury, and it's like when you fall down, sometimes you get a little blue patch on your arm or a leg. It's a contusion. It's similar to that. There's a little bit blood spot on the brain. And sometimes you may see more than one. The danger about contusions is that, here's a contusion. Here's two pictures with contusion. The white stuff is the blood. What happens is they can kind of coalesce together. As hours go by, they can coalesce, and then it can cause a significant problem. So those patients, even if they're completely normal, neurologically intact, and you need to admit them, or at least watch them for several hours, because those can cause problems, and repeat the CT scan if necessary. And, they can cause sometimes some neurological deficits. So we talked about diffuse brain injuries earlier, and I'm going to skip that. So diffuse axonal injury, like I said earlier, the brain CT scan, what happens is it gets swollen diffusely. You don't see blood, but the brain gets swollen, and when you look at the CT scan, you'll see that there's loss of gray and white matter on the edges. And I have a CT scan picture. I'll show you that one. And the ventricles, which are normally, which you can see with the fluid-filled, CSF-filled ventricles, they are compressed, what we call slit-like appearance. You see, that means the whole brain has swollen, edema. And here's a normal brain. You can see, if you look at the edge of the brain, you see this gyri and, gray and white matter margins right there, fairly clear. Ventricles are nice and good size. And say another normal CT. And here's what happened in diffuse axonal injury. Do you see those margins, like the one you heard earlier? Here's compare this margin, the margin of this brain, and compared to this one, it's kind of smoothened out because of the swelling. And you don't see the ventricles clearly. So there is no blood, but it has caused edema. This type of thing usually happens when there is some kind of an insult at the time of the injury. So if there's an accident or something or a fall, and the patient has either had a blood loss causing hypovolemia or shock, and also if the patient sustained a hypoxic injury to the brain, and that can cause this this kind of problem. And usually these patients don't do very well, and they can get significant neurological deficits. So how do you manage a head injury? General principles. First, after you do your evaluation, if the patient is hemodynamically stable, you do a CT scan. Remember, if the patient is not hemodynamically stable, your primary survey is to resuscitate these patients, to stabilize this patient before you do that kind of studies. If the patient is sent to CT scan in an unstable situation, you're going to have a severe problem in your hands. So always manage the patient, stabilize the patient, then CT scan. And always remember to protect the C-spine. Remember I said yesterday in my lecture, if a patient had a head injury, suspect a C-spine injury always, unless proven otherwise. So always think about the C-spine injury. You must always get alcohol and drug levels, but don't forget to get glucose level. Like Mr. Mostel mentioned in his lecture yesterday, you see a patient who comes in any kind of unresponsive situation, regardless whether it's trauma or medical situation, unresponsive patient, you must get glucose level checked, because hypoglycemia can cause. Oh, yeah, I cannot see that. Yes. Oh, okay. Well, I'll go back a little bit and show you the. Okay. And see how the gray and white matter. You can see this gyri coming in, and here's the ventricles, and the ventricles are nice, and this is filled with CSF. And then if you come here, it's all that gyri and the gray and white matter is lost. You cannot see the ventricles because it's edema. So when you want to consider CT scan, you really don't want a CT scan everybody who comes in, but you must do it if you feel that clinically it's necessary. There are some guidelines, they are not rules and regulations, but guidelines you can use. If the patient had a GCS score of less than 15 after 2 hours of the injury, think about it. If the patient has definitely an open or skull fracture, there's no, that's a given. You must do it. And if the patient has a basal skull fracture with, barrel sign, hemotympanum, racuna sign, and otorrhea, rhinorrhea. So let me take a couple of minutes to explain this now. Basal skull fracture, it can cause either with or without CSF leak, or also with or without seventh nerve or eighth nerve damage. Seventh nerve is facial nerve, and eighth nerve is hearing. And if you don't have those, you get the raccoonitis. That's a retroorbital hematoma. Have you seen patients with if they had a head injury, they have blood, all the purple around the eyes? and then the purple color behind the ear, that's a retroauricular hematoma. So I want to tell you a little story about this. This might embarrass my wife. So we were in Saudi Arabia, and one day she was with a bunch of little kids, and I was, I think at home or at work, I can't remember. Anyway, she was kind of running with these kids, tripped on the curb, fell right on her face. And she came home fully bruised up. Next day she had raccoon eyes. She had a teeny bit of blood on the behind the ear. Fortunately, no seventh nerve paralysis, no eighth nerve paralysis, no CSF leaks. So CSF leaks is when the CSF fluid leaks to the nose, which is rhinorrhea, or if it leaks to the ear, which is otorrhea. She didn't have those. So I talked to one of my neurosurgery colleagues, and he said, Leonard, since she doesn't have all those signs, she's allergic to no loss of consciousness, just keep an eye on her since you're a physician. If something happens, changes, let me know. So next day she was actually much better, little sore, little headache, but she was fine. But she went about doing shopping, things like that. All our friends who met her in the shopping complex and things, I would look at her and kind of avoided her, didn't ask her what happened. And this went on for about a week, and then one day she and I were together at the shopping center, and another friend of mine, a physician, and his wife came by, and we stopped to talk. And my friend, of course, is a physician. He said, Leonard, Sharon, what happened to you? And she kind of, didn't say anything right away. And I said, with a straight face, I said, she did not put enough salt in my food. Because a lot of people before that didn't ask because they thought I beat her up. So spousal abuse, yes. If a woman comes, for that matter, even a man comes to the emergency department with injuries like that, you must think about spousal abuse. Trust me, I did not hit my wife. She wouldn't be here today if I did. Anyway, talking about spousal abuse, one of the nurses one day when I was working in Virginia came. She's a strong woman. She came. She was fully bruised up, injured. And, of course, she was brought by ambulance, and then, I didn't see her. The other physician saw her. But I asked her, what happened? Her boyfriend beat her up. Actually, her boyfriend beat her up. But 4 days later, I went to work, and the boyfriend came by ambulance, fully injured. And I asked the nurse, what happened? She beat him up. And I said, good for her. He deserved it. Anyway, think about spousal abuse. It can be, and children. So I think Mr. Morse touched on that subject yesterday. Always suspect children or even adults, elderly people, so think about that. So anyway, if you see signs of like that, CT scan is indicated. Vomiting, the recommendation is if you vomit more than twice, but it is kind of a, clinical decision. Older people, more than 65 years, but then again, like I said, if you suspect some clinical problem, you can get a CT scan even if they are under 65. Definitely patients on anticoagulation medications, but I think one of our colleagues did a study, Hernando did the Vincent study on head injury and CT scans on research. Is it published yet? Yeah. So that's a study done. One of our colleagues who worked with me, at the hospital, did a study whether they really need a CT scan or not. I have not seen that yet. But as of now, if the patient's on anticoagulation medications with a head injury, CT scan may be indicated. Pediatric patients, and because there's so much radiation, we try to reduce, we observe. I like to, if the child is playing, running around, active, I tell the mother, would you like to wait a few hours because I really don't want to radiate this child with a lot of CT scans, you see. Because you have to be concerned about that. There's a lot of radiation in CT scans, and especially children. So we observe them. But there's one indication, a recent research said if there's children about 2 years old, toddler age, If they have a significant scalp hematoma, that may be an indication to get a CT scan. Loss of consciousness of more than 5 minutes. And again, it's a judgment call. If the patient is amnesic, my son had a fall playing football, which is American football, and he was brought by his friends to the house, and he was confused. He kept asking the same question over and over and over again, and he couldn't remember anything, what we said. And I took him to the ER myself, and we got a CT scan. Fortunately, he was okay, and he was fine next day. So those are, mild concussions. And if the mechanism of injury you suspect was a dangerous mechanism, like a high-speed motor vehicle accident, falling from a ladder from a fairly, high up, things like that. The patient is symptomatic. If they have a significant headache, if the patient had a seizure after the injury, and if the patient has some focal neurological findings, then you must get a CT scan. That is important. So we need to do a mini neurological exam during our evaluation. The purpose is to determine how severe the brain injury is. You need to then, that way you can monitor the deterioration, meaning here are the findings now. 2 hours later, it may be different. So that's why you have to monitor, document the time, like I said yesterday. Always document the time and document your findings in detail. And then the next person, if you're not there, your shift is over, the next person who comes along can compare his or her findings with your findings. And then, of course, you need to document all the other injuries as well. So the things you want to document, of course, level of consciousness, which we use GCS, and we talked about that already. Check the pupils. Are they dilated? Are they reactive? And see if there's any motor weakness as well. So how do you manage mild head injuries? Like I said, 75% fortunately are mild. They may have a history of disorientation, amnesia, and they may have transient loss of consciousness, but now they are awake and alert and oriented and talking. But unfortunately, now this is GCS of 15 now. GCS of 15, but 3% of these patients may deteriorate. So you need to either observe some of these patients or give appropriate instructions to the person who's going to take that patient home, a responsible adult. Now, if the patient comes with another fully intoxicated, drunk friend, you can't discharge that patient to that person. So in that case, you may have to keep the patient until somebody responsible comes, but that is always think about it. So ideally, we can think about CT scans in these patients. The study was done, 658 patients classified as minor head injuries, which means GCS of between 13 to 14. 18% of them had abnormal initial head CTs, but doesn't mean they all had problems. Only about 0.5% needed surgery. A GCS of 13, 25% had abnormal initial head CT and 1.3 required surgery. So you have to always think about this, even though it's a minor head injury. Skull X-rays, these days we don't do it. And in rural area, if there's no CT scan, if you want to check for, maybe skull fractures or air in the, inside intracranial air or something like that is helpful. C-spine, remember, like I said, it's important. So if you want to discharge a patient with mild head injuries, always give a head injury instruction sheet. And we have a standard instruction sheet we give to all our patients, a printed paper. In addition to that, I personally always kind of go through this verbally one by one, and I always ask them, do you have any questions before you leave? Which I ask every patient before they are discharged. So if the patient has, normal CT, remember you can discharge. If the patient has no companion, you may want to observe in the ER or admit if necessary. Abnormal CTs, definitely you need to admit them or contact a neurosurgeon. Here are the discharge instructions for if you are going to discharge the patient. And tell the family if the patient becomes increasingly drowsy, try to wake the patient up every few hours to see if he or she can recognize you. And even children, I say that, if their child can recognize you, and if they have nausea and vomiting, if they have seizures, or we call fits here, if they have discharge or bleeding, if they complain, I have some weakness or numbness or in one side of the body, if they have confusion or erratic behavior, check the pupil at home with a flashlight, you call a torch. And if the vital signs, like if the heart is beating too fast or irregular, things like that, which usually our families can check. How much time do I have? Time's up. So I'll take 5 minutes to. So moderate head injuries, 15%. They all need CT scans. These patients can still follow commands but are confused, and approximately 10 to 20% can deteriorate and manage like severe head injuries. These patients, we don't have time. We have to aggressively treat them because they are usually multiple injuries and they can be really serious. So they are the ones you have to be really careful to make sure there's no secondary brain injury. And they cannot follow simple commands, and they're usually hypotensive or hypoxic, so you have to address those issues. So primary survey, manage the airway, if necessary, intubate. If they're hypotensive, address that issue with the blood fluid. Remember, I said yesterday, head injury does not cause hypovolemia, hypotension, unless late stages they can get hypotension when there's medullary compression is involved. And hyperventilation, be very careful not to over-hyperventilate. So always treat the hypotension. Neurological exam, you do that. We already talked about the neurological exam, but I want to mention a few other things quickly, unless I'm kicked out of here. So management. Medical therapies, I quickly mentioned. So patients with hypotension, make sure you hydrate them with either Ringer's lactate or normal saline, but you have to be careful not to overdo it, because if you give too much fluid too soon, they can cause cerebral edema. So be careful. And remember, do not use any IV fluids with glucose, because the brain, in a patient with head injury, brain is not ready to metabolize. So you don't need that. That's not necessary, unless they are hypoglycemic. So if they are normal sugar or even high sugar, remember, you only use normal saline without glucose or Ringer's lactate. Now, hyperventilation, I want to quickly touch because this is important. Many years ago, it was advocated that these patients needed to be hyperventilated. It is not so now. The idea is to maintain the PCO2 of 35, which is the low end of normal. Normal PCO2 is between 35 to 45. The only time you hyperventilate, it's recommended for hyperventilation, is that the patient is deteriorating in front of you. And if a normal patient who comes now has new neurological deficits, so you talk to the neurosurgeon, say he's going downhill, I'll start hyperventilating briefly, not for a long time, and hyperventilate and maintain a PCO2 of 25 to 30 to help to cause vasoconstriction. Remember, if it is too much vasoconstriction, it can cause ischemia of the brain. So that's why we don't want to do that for too long. Mannitol, again, if the patient is deteriorating, you can give mannitol. The mannitol is a strong osmotic diuretic, so therefore it can cause patient, sometimes it can cause hypotension. If the patient is already hypotensive, you don't want to give mannitol. So routine use of mannitol is not recommended. Again, if that patient is deteriorating, you not talk to the neurosurgeons. And Lasix can go along with it. Steroids have no place in trauma. We don't give steroids anymore for head injuries. Spinal cord injury maybe is a different issue, but not in the head injury. And barbiturates, this has been used. This is used even in some places. The idea is that this will help to reduce the intracranial pressure and reduces the metabolic rate. But again, you cannot use this if the patient is already hypotensive, because barbiturates can cause further hypotension. So you don't want to compound the problem. Anticonvulsants, about 5% of head injury patients can develop seizures or fits later in life. 3 main factors for late epilepsy or fits: early seizures within the first week, intracranial hematoma, depressed skull fracture. So the common anticonvulsants, you need to use either phenobarbital or phenytoin, but you don't give phenytoin prophylactically. In fact, there's some research published to show that phenytoin can cause inhibition of the brain, rehabilitation of the brain. So only if there are seizures. Now, when the patient is actively having fits, you give Valium or lorazepam or diazepam and benzodiazepine. But remember, that only controls the muscle activity. It doesn't control the actual brain activity. So many times doctors will give that and feel comfortable that the patient is now okay. It's not so. So remember, if you give benzodiazepines, it first treats the doctors and the nurses because they feel quite happy that the patient is looking better. But you have to always accompany that with an anticonvulsant. Scalp bleeding, control with, make sure they are clean pretty well, irrigate them, remove all foreign bodies, look for CSF leaks, look for skull fractures, and suture as necessary. And then early neurosurgical intervention if the patient has intracranial hematomas or if there's significant neurological deficits. And burr holes, quickly. You see, burr holes were recommended many years ago, and especially in rural areas because then there's no neurosurgeon. But burr holes, today we don't recommend because two things. When you do burr holes, you're going blindly, and you may not hit the actual hematoma. Secondly, burr hole is only about 10 to 15 millimeters in diameter, and some of the blood may come out, but then it gets clogged up, and so it doesn't really do any good. If you're really in a bind like that, you can do a bone flap craniotomy, which I cannot do. It has to be done by by a surgeon who has been trained to do that. So I think Dr. Gunatilaka may have experienced that in the areas where he has practiced before. And finally, brain death. He says, no, this is the point of no recovery for brain function. And how do you diagnose this? GCS of 3, pupils dilated and non-reactive, no brain reflexes, meaning doll's eye and caloric cold reflexes. Absent, they don't have any breathing response on their own. So how do you confirm that? You can do an EEG, you can do a cerebral blood flow study, and you can do those tests and cerebral angiography. But remember, those who have had hypothermia, exposure to low temperatures, or hypothermic already, or barbiturates, may give a false brain death. So you have to let those things first, warm the body or barbiturates to be removed from the body before you can determine that. In children, sometimes you need to delay deciding the brain death because they have a remarkable capacity to recover. So you need to give more time. And if you suspect that this patient is brain dead, but other vital signs are still intact, you need to contact the organ harvesting after you get the consent from the family members. Summary: initial management of the head injury patient is very critical. Always do the ACBCDE approach. Of course, most of these things are done simultaneously. The most important thing is that prevent secondary brain damage with appropriate treatment for hypovolemia and hypoxia. And make sure you identify the patients who need immediate surgery because you don't want to delay those as soon as the patient is stabilized hemodynamically. And then make sure you transfer these patients to higher level of care where neurosurgery is available in a timely manner. And this is about 2 hours from my home. Yosemite Valley is a beautiful, beautiful area, the waterfall. And this is South Lake Tahoe, again, which is about 2 hours from my home. A beautiful place. My wife and I sometimes go and have a little day tour there and have a picnic and enjoy and come back in the evening. It's only 2 hours. And that's South Lake Tahoe also. Thank you, and I'm sorry. I apologize for taking extra time.
Thank you, sir. Next, I would like to invite Dr. Gamini Gunatilaka, Senior Consultant Surgeon, Sri Jayawardena General Hospital, Sri Lanka, to talk on the topic, the current emergency and trauma care situation in Sri Lanka.
Once again, I must thank IIHS for inviting me for this very important conference on trauma, which is a very important problem in Sri Lanka. Now, yesterday I was asked to speak on a specific subject called anti-personal minds. What I am going to talk today is a general aspects of trauma in Sri Lanka, and this is based on my experience of treating patients, trauma victims in our country for 30 years in different parts of Sri Lanka, and what I am going to tell you today is supported by data from various sources. For interest's sake, I have also included a lot of photographs and also some case reports to make this lecture more interesting and also to make you understand the people in Sri Lanka as well as the foreigners who are here, the gravity of the problem of trauma in Sri Lanka. It is a very serious matter. But I am sorry to say very little has been done and nothing will be done. I cannot do anything about it, you cannot do anything about it. And I will tell you at the end of this lecture who can do something about it. So we hope that something will be done very soon. I have been speaking about trauma in Sri Lanka at various meetings over these years, but sorry to say, very little has been done. Now, trauma is a major cause of death and disability throughout the world. It is regarded as a neglected killer or the neglected stepchild of modern medicine. Why do people say that? Because the money that is spent on trauma prevention, trauma control programs is much less than the money that has been spent on other important aspects, maybe diabetes, heart disease, strokes, HIV and cancer. Much more money is spent on those aspects of medicine rather than trauma, which is also a major killer throughout the world. You would have seen some of this data when Dr. Leonard presented this lecture yesterday. It is the leading cause of death in the first 4 decades in USA. Deaths amount to 150,000 per year. The incidence of 1,000 per million population, and the cost is enormous. You can see the cost. Now in Sri Lanka, we do not have data like that. And that is the biggest problem we face in Sri Lanka. But we know that in Sri Lanka, the leading cause of hospital admissions since 1995 is trauma. And that the war would have contributed some aspects to that. But even today, the leading cause of hospital admissions in Sri Lanka is trauma. And if you look at the hospital deaths, the ranked number is 11. So these are different aspects of trauma that I am going to talk to you about in this country. You can see, I showed you some pictures of mine injuries. We have stab injuries, people falling from trains and buses, anti-personal mine injuries. Then there are children or patients gored by animals. Then the problem of burns, kerosene oil bottle lamps. Even today we see that in Sri Lanka. So I will try to highlight these aspects with some photographs and case reports of patients that I have treated in the hospital that I worked. So in this lecture, I will touch upon these aspects, the incidence and causes of trauma, the impact of trauma on society, the trauma care services in our country, and my recommendations for controlled and improved care, because I consider this a serious problem. Now, the first thing that you encounter when you want to study trauma in Sri Lanka is this. We don't have a central data collection unit. And therefore, if anyone wants to study trauma, you have to go around various sources. And the figures we do not know whether these figures are reliable. So what are the sources? We can go to the annual health bulletin of the Ministry of Health, but the latest one that had been published is 2008. Then we go to the police department. If you know someone in the police department, they will give you the data. Otherwise, they will say, please, don't come and worry us. Then we go to the Department of Census and Statistics. Once again, you have to know someone there. Epidemiology unit, medical statisticians. We can gather data from hospitals and accident services. And if we look at this data, we will know that it has significant morbidity and mortality. So now let me show you some of the data. You can see 1991, the rank was number 3. The latest bulletin we have is 2008. According to that, the rank is 1, the number 1 cause. Number of admissions, over 500,000. And it amounts to 15.6 of hospital admissions. Total number of hospital admissions amount to more than 4 million. So you can see more than 500,000 admissions are to hospitals in Sri Lanka due to trauma. And all these patients are getting free treatment. Whatever hospital they go, they get free treatment. Whether it's a victim of road traffic accident, stab injury, assault, everyone is getting free treatment. Now, what are the causes of trauma in our country? We have road traffic accidents, occupational accidents, burns, usually kerosene oil bottle lamps, or maybe LP gas burns. We had burns caused by bomb explosions and other explosive devices during the war. Then we had war injuries, but at the moment we don't have a war. But we have isolated cases of gunshot injury almost every day. Then there are home accidents which occur in every home due to negligence, due to accidents. Then assaults and stab injuries. These are very common during the New Year season, April and December. And most of them are under the influence of liquor, especially the special brew in the village called Kasippu. Now, road traffic accidents. This is not a problem confined to Sri Lanka. It is a universal problem. Road traffic accidents occur all over the world. But we have not taken enough precautions to prevent this problem in our country. Road traffic accidents, the cost in billions. You can see the amount of money the government of Sri Lanka has to spend for victims of road traffic accidents. Road traffic accidents, the latest figure that I got is 2012. The total number of accidents, you can see the numbers going up. 2010, 37,000. 2012 gone up to 42,000. There's an increase in the number of road traffic accidents in Sri Lanka. The number of fatal accidents have increased and the number of deaths have increased. In Sri Lanka, 6 people are dying on our roads every day. 6 people are dying on our roads every day. Injured, the number of injured people, you can see that also has gone up. In 2002, there were only 18,000. In 2012, it has gone up to 30,000 or more. And most of them, you can see the young group, 21 to 55 years. More than 65% of these victims are in that young age group. 6 people are dying on our roads every day, and there are 135 accidents per day. What are the vehicles involved? The motorcycle is the commonest vehicle involved in accidents. The trishaw, you can see how they go on this trishaw. The 3-wheeler or the Bajaj, though people who have come from overseas, please don't get onto this trishaw. You may not be able to go back home. The trishaw is very dangerous because it has only 3 wheels. And these people do not respect the highway code. Then the motor car, private bus and van. Even private buses are very dangerous. Then who are the victims? The dead victims are pedestrians. The commonest victim who dies on the road is the pedestrian, because the pedestrian doesn't walk on the pavement. He's walking on the main road. You can see that even near the hospital. And they don't use the pedestrian crossing. Sometimes the vehicle doesn't stop at the pedestrian crossing. Pavements sometimes are occupied by other people. So the pedestrian is the one who has to suffer the injury. Motorcyclists, passengers in vehicles, cyclists and the driver. This is the order of victims. Now I want to show you a very interesting case to show you the morbidity that is associated with road traffic accidents. This young man was a trishaw driver. One day after his work, he finished work at about 10 o'clock in the evening and he was going home and he met with an accident. Naturally, working the whole day, he would have been sleepy. And he went and knocked on a vehicle in front. The trishaw crashed. The entire windscreen was shattered. and glass piece cut his neck right up to the cervical spine. Right up to the cervical spine means all the important structures in the neck were cut. The skin, the trachea, thyroid gland, both recurrent laryngeal nerves, esophagus, everything was cut except the internal jugular and the carotid artery. All the other structures were cut. So this is a very serious injury. He was brought to hospital. There what happened, he had a tracheostomy and also a primary suture of the esophagus. This is the trishaw. So he had a tracheostomy and a primary end-to-end suture of the esophagus to restore the continuity of the esophagus so that he can take his food and drink in the future. But we know when you suture the esophagus together, you will end up with a stricture because the esophagus, unlike the stomach, small bowel or the large bowel, cannot be mobilized to get adequate length. And also there is problem of the blood supply of the esophagus. So what happened, he developed a stricture and he could not swallow any food. So they did a jejunostomy. A jejunostomy means a tube was inserted to his small bowel so that he can be fed, but only liquids. So this young man of 25 years has a tracheostomy and he has another tube called jejunostomy to feed him. He cannot speak because of tracheostomy. He had lost his voice. And those hospital authorities told him, young man, we cannot do anything more for you. You go home. And he was given another tracheostomy tube. He was trained to change this tracheostomy tube. And he was also asked to buy a mirror, a funnel, and a jug. So he bought all that. He went home. And every morning, he used to change this tracheostomy tube by looking at this mirror. He washed the tracheostomy tube, replaced with a new tube or the other tube, washed it nicely, and change. He cannot speak. He cannot eat. He cannot drink. He is feeding through this tube. But how can this man, 25-year-old man, go on living like this for so many years? Suddenly he came to our hospital and he came to my ward and I thought something must be done for this man so that he must get back to his occupation. He cannot be a doctor, but he can be a trishaw driver once again. So you can see this man changing his tracheostomy tube in my consultation room. And this is how he was feeding, a jug and a funnel and the fluid going through this tube into his jejunum. That was the only way he could take his nutrition. Then we did a contrast study of his esophagus. A barium swallow was done and you can see a stricture. A stricture in the upper part of the esophagus or the cervical esophagus, a narrow part which prevents the food and the drink or the fluid going down, which caused the dysphagia. So I thought something has to be done. Once you get a stricture in the esophagus or a narrowing of the esophagus, that esophagus is useless. It must be removed and put in the dustbin. And then we must construct a new esophagus. And that can be done using the stomach or the large bowel. So this is the stomach, which has been now mobilized and taken out of the stomach, abdomen, and now it has to be taken through the chest into the neck and connected to the normal part of the esophagus to restore continuity of his alimentary tract or the digestive tract so that he will be able to eat and drink in the normal manner once again. So we did that operation. The stomach was mobilized from the abdomen, taken up through the chest, brought to the neck, connected to the cervical esophagus, and he was able to eat and drink. You can see the tube has now been removed. He doesn't need the funnel and the jug, but he still has a tracheostomy tube. And then I referred this patient to our ENT surgeon who did something in his larynx, and he was able to remove that esophagus, the tracheostomy tube as well. His voice returned, but not normal, but he had some voice. We had removed his tubes. He was able to take food and drink in the normal manner, and now he has gone back. He took a loan and bought another trishaw. This I am showing you to see the gravity of the problem these people undergo because of accidents. It is serious morbidity, and this man could have died if that glass cut his main carotid artery or the internal jugular. Now, what is interesting is the day he went and bought this trishaw, he came driving this new trishaw to my hospital, and he wanted me to be his first passenger. So that was a very great day for me. For me, it was a pleasure going in this trishaw. It gives me greater pleasure than going in a Lamborghini. So this is just an illustration to show the gravity of the problem, the morbidity, and also the enjoyment that we can have when we see these people getting back to their occupation. Occupational accidents is another problem in our country. As you know, Sri Lanka, 37% of our people are employed in agriculture, not in the urban areas, in rural areas. Most of them in paddy cultivation and other types of cultivation. Then there are also industrial accidents. Agricultural accidents, there are many types that we encounter, mostly in rural areas, and these are some accidents that I witnessed when I was working in outstation hospitals. So there are accidents. I'm sure most of you would not have seen these problems because you don't see this in Colombo. We have trap gun injuries. Then there are injuries caused by animals, both wild animals and domestic animals. Injuries caused by various types of machinery. People sustain injury following falls. What are these trap guns? Trap guns are guns used by the chaina cultivators in cultivating in remote villages to protect their crops from wild animals, especially the wild boar and the deer. This is a trap gun that is manufactured by these farmers, consisting of a metal tube which is packed with explosive devices. One end is closed, the other end is open, and you can see the trigger mechanism. The level of that cord depends on which animal they expect to come there, maybe wild boar or deer. Now, another fellow farmer passing that and tripping over this cord will cause explosion of this gun and the patient gets injured. And usually the injuries are below knee. Sometimes it affects other areas of the body. This is a farmer setting a trap gun. And sometimes the trap gun explodes in the person's hand, causing serious problem, you can see. So this is disability. It is permanent disability. Why do they use trap guns? Because they are not given other guns or shotguns to protect their crops from these wild animals. So they have to depend on trap guns. Trap guns are illegal, but no one has been charged for this today. So they have to use these trap guns, and sometimes it explodes in their hand, and this is what happens. He will end up in an amputation. He is disabled for life. This farmer cannot work in the paddy field anymore, and he will have to depend on the state for the rest of his life. Trap guns, I said, usually cause damage in the region of the knee joint or below. Here is a trap gun injury at the level of the knee joint. Multiple pellets have gone through his knee, and some of them are embedded inside the joint. So he is again disabled. And this is a bad compound fracture. You can see small metal fragments. The bone is shattered. He might end up in amputation because in addition to the bone injury, there is soft tissue injury, damage to blood vessels and nerves. So some of them end up in amputation. Then there are injuries caused by animals. This is a bear, you can see. Some of these people cultivate in the jungle areas, and the bear, if you see a bear, please don't disturb the bear, because the bear will jump on your face and take your scalp away. Although the bear does not eat the scalp, he is a vegetarian. But he causes serious damage, you can see. Almost descalping injuries, facial injuries, fracture mandible, fracture nose, so complete disfigurement of the face, and these are the problems. Elephants. Today there is a big problem with elephants. What is called the human elephant conflict. The human is attacking the elephant and the elephant is attacking the human. That is called the human-elephant conflict in Sri Lanka. This elephant attacked this man. You can see the whole face, neck, upper part of the body, chest swollen because it ruptured the trachea. And air escaped out, causing what is called surgical emphysema, air in the subcutaneous tissue, difficulty in breathing. So the treatment is very simple, but must be done as soon as possible. It's tracheostomy. You do a tracheostomy and the patient will recover. Here is the patient after recovery. Then we have other wild animals. This is another story I want to tell you. This child was attacked by a wild buffalo in a remote part close to Batticaloa. This child was brought to hospital when I was working at Polonnaruwa. Got injured late in the evening, and all the viscera came out, what is called evisceration. There was no first aid, no paramedics, no ambulance, nothing. And the father of this patient had to find a van to transport this child to Batticaloa, from Batticaloa or Valachena to Polonnaruwa hospital, which took another 4 hours. And the child was transported on the floorboard of this van without drips, without first aid, without anything. And on admission, the child was in a collapse condition with multiple perforations of his bowel. And everything has come out, the small bowel, and in a state of shock. So these patients need immediate attention. We cannot transfer them to another hospital, they'll die on the way. So these are things we have to attend immediately, resuscitate the patient, take to theatre, do a laparotomy, repair the bowel perforations, and child will recover. But must be done as soon as possible. This is another machine. I'm sure people living in the outstation areas would have seen this machine. This is called the winnowing fan, which is used to winnow the paddy grain. During harvest time, you can see these machines being used. Commonly in paddy fields, you can see a fan without any protection. No protective cover. There are 2 fan belts which are also open. Now people using this machine, getting too close to this machine, what will happen? They will get injured by this fan blade or by this the fan blade or by these belts. This is what they do, what is called winnowing of the paddy grain. That is cleaning of the paddy grain by the blowing or the wind caused by this rotation of this fan. But it's very dangerous. So what has happened? Multiple amputation of the fingers. Then the other problem I want to talk to you briefly is burns. Kerosene oil bottle lamps are still being used in our country. Then there are others who sustain electrical burns. LP gas burns used for cooking purposes. Bomb explosions, burns due to bomb explosions, we saw in the past. Then there are others who sustain injury from corrosive acids, either by swallowing these acids or people throw acids onto other people. And this is the kerosene oil bottle lamp which is used by the people who do not have electricity in their homes. This is the source of light for the poor people of Sri Lanka. You have kerosene oil inside, the bottle topples, the kerosene oil leaks out, and the entire area catches fire. And the people around also will get burnt because their clothing will catch fire. So the amount of victims we have, over 13,000 victims, 220 deaths, the cost of managing these burns, over 2 million per year. And we have burns units only in very few selected teaching hospitals, one in Colombo, one in Kandy, and maybe one in Galle. So most of these other patients with burns are treated in general surgical wards. Here is a victim of a kerosene oil bottle lamp. You can see the extent of burns. And these actually need specialized care in burns units. But because we do not have specialized burn units, adequate number in our country, most of them are treated in general surgical wards. Here is another child, you can see, burned. sitting on their bed covered by a mosquito net and treated by the open technique of applying silver sulfadiazine and leaving it open without any dressing. This is the child. You can see burns have healed. Luckily, these are not deep burns. They are superficial burns. In 2 weeks, the scab will come out and there will be regeneration of the skin. This is a man who has taken corrosive. Corrosive acids have been taken with the idea of committing suicide, but he did not die. Then what happens? He becomes a problem for the surgeon. Because he has taken corrosives, his esophagus has got narrow. The stricture of the esophagus has developed. He cannot take any food or drink. He is malnourished, he is emaciated, dehydrated, anemic. So first of all, before we operate, we have to do a jejunostomy or a gastrostomy, feed him for 3 to 6 months, improve his nutrition, and then plan surgery to give him a new esophagus. These are burns I showed you yesterday from bomb explosions, which also needs active resuscitation because they need lot of fluid. This is what happens if burns are not treated properly. Keloid formation, contracture, scars, disfigurement. Now the other problem of treating burns in Sri Lanka is that some of them do not come to hospital. Some come to hospital, after some time they go and take native treatment. And they get this disfigurement due to contractures. Here is another child who went for native treatment, got a contracture, unable to raise the arm because of a contracture in the axilla. So needs plastic surgery. We have to remove that contracture and skin graft. So these are all problems faced because they do not have best care at the primary time of injury. Another patient with burns, high mortality, almost 90% burns. So with the idea of preventing these burns, a surgeon in Sri Lanka, one Dr. Godagumbara, recommended this safe bottle lamp. It is like a small Marmite bottle with a heavy bottom and a screw cap, so that even if it topples, the kerosene oil does not leak out, and that area is safe. So these have been distributed to people who are using the bottle lamps in Sri Lanka, and that has reduced the amount of injury or burns in remote villages. Home accidents that can occur in any home, especially children. They play with different objects. This child was playing with a wooden spike. He fell and the spike went through the chest and was brought to hospital acutely dyspneic. Face is swollen, neck is swollen, chest is swollen. Acute pneumothorax and surgical emphysema. Now these must be recognized as soon as possible. I will tell you later on where they are treated in this country. Because we do not have accident services or emergency departments, they are brought direct to the surgical ward. So someone there must attend to this type of patient as soon as possible, and they will recover provided you give the best treatment, insertion of an intercostal tube or a chest drain, and they will recover. Stab injuries, I told you, very common. You can see a stab injury, you can see a stain on that knife. This knife was inside this man's head, stabbed by the own brother. He could not pull it out again. So he referred this patient to the surgeon to pull it out. But before I pulled it out, I took a photograph. This is another patient who lost the eye after being cut on the eye, lost the eye. Bow injuries, I am not going to talk to you on bow injuries because I think I spoke to you about these yesterday. This is the Johnny mine. You can have a better view of this Johnny mine today. You can see the small box with the lid, the wire, 2 pen torch batteries, detonator, 25 grams of explosive. And that is the damage. And these are affecting civilians unless demining has been done completely. Now, this is another aspect I want to tell you about facilities for trauma care and pre-hospital care in our country. Now we know management of trauma is a coordinated effort from the time of injury, hospital, that is pre-hospital care, hospital care, and management rehabilitation afterwards. This system is not well developed in Sri Lanka. These are the things. First of all, we must notify that there has been an accident. There must be a system of good communication. There must be response and treatment and emergency facility. So these are the key elements for emergency medical care, which are used in most of the developed Western countries. But this system is very primitive in Sri Lanka. The Americans who are here will be familiar with this number, 911. If you have injury or accident or any emergency, in America you dial 911 and the ambulance station will receive this call and dispatch the ambulance to the victim. And they will also communicate with the hospital. They might communicate with the fire brigade or the police and then attend to this casualty. The casualty is brought to hospital. The doctors in the emergency department are kept informed and they are ready to treat this emergency. Sometimes large number of casualties come at the same time. Now in Sri Lanka, what happened to these patients? In Sri Lanka, we have what are called teaching hospitals, provincial hospitals and base hospitals. We do not have trauma centers, except the one on the other side of this building, the accident service, and a few units like that in Galle, Colombo South, Kandy. But they are not developed to this extent as the accident service in Colombo. The trauma center in Colombo, which is very well developed with all the facilities, all the expertise is there, which is not available in the accident services or the trauma centers in other parts of the country. So what happens to the trauma victim? They go direct to the surgical ward, or what is called casualty ward. And the first person to see the patient will be the house officer. The house officer or the medical officer in the ward will be the first person to see the casualty. There is no notice of a casualty coming. Some of them are not coming in ambulances. They come in whatever vehicle that is available. It may be a bus, it may be a truck, it may be a tractor, or it may be a trishaw. So you can see there can be damage during transport of these patients. And majority of these, we do not have the multidisciplinary approach that a trauma victim should have. And we also have another problem in Sri Lanka. You can see a victim, a fracture victim, patient with a fractured femur being treated like this. These are not treatment in hospital. These are treatment by various types of what are called osteopath in Sri Lanka. That is another problem because sometimes they come to hospital for a few days, we put a plaster. They leave the hospital, they go to that osteopath, he removes the plaster. If I ask anyone in this audience what this is, I don't think they will know. This is, that osteopath visited the orthopedic ward one day and he saw patients being treated on traction. He saw a weight being hung and the foot end of the bed elevated, head down. That is called traction for treatment of lower limb injuries. So he went back to his medical facility and he said, I will also do fracture treatment by traction. And he got hold of a big stone and tied that stone to his leg. But there is no traction. This boy had a fracture femur and he can rotate down this stone. He can rotate. Anyway, I had the chance to visit this osteopath and take these pictures for the audience today. I did not tell him that I am a surgeon. I told him I am a journalist. And I am going to give you a lot of publicity by showing these pictures. So he allowed me in. So this is the accident service in our hospital. one of the best, and anyone working in this trauma center will get a very good experience in managing all types of trauma that you can see. Now, some figures from accident service. You can see the number of patients who are treated. Over 105,000 patients treated. Admissions, 66,000. Transfers from other hospitals. Deaths, nearly 200. Burns, 714 patients with burns admitted to accident service in 2012. And most of the victims are road traffic accident victims. There are occupational accidents, home accidents, assaults, what I showed you. So there is a mixture of patients coming to this accident service with different types of problems, and it is the best place for anyone to learn trauma. So now what can be, I have shown you the gravity of this problem in Sri Lanka. What can be done? First thing is, I think, first matter is that we must recognize trauma as a disease. If you do not recognize trauma as a disease, we cannot have any plans to counter this problem. I told you this is the commonest cause of admissions to our hospitals, more than any other problem. More than 500,000 admissions to our hospitals. Therefore, we must recognize trauma as a non-communicable disease. Now, in Sri Lanka, we have so many programs to control diseases. We have what is called malaria control program, another program to control filaria, rabies, sexually transmitted diseases. We have leprosy control programs, like that, cancer control program, anti-chest problems. We have many programs like this, and these programs are initiated to control diseases. And I can tell you malaria has been completely eradicated because of this program. So we must first of all recognize trauma as a disease, and therefore this is the weapon that we must use, the weapon of epidemiology. And there is a big role for health administrators and planners in countering this problem. So we must start a trauma control program in our country. We need a trauma control program which will look into all aspects of trauma. So, I told you, first of all, we do not have good statistics. To have any control program, we need to have very good database. We must know the types of trauma in different parts of our country. So, we have to gather data. Initially, we have to gather data. And this is very simple because in our hospitals, there is a system of gathering data from communicable diseases. If a patient with dengue fever goes to hospital today, there is data collected and sent to the Colombo head office. So we have trauma victim going to hospital, notification goes to the medical officer of health, from there it goes to the regional director, trauma control program, and the director general of health services in charge of this program. And this trauma control program will then guide in the prevention of trauma, pre-hospital care, hospital care, rehabilitation. Another same way, you can see the trauma control program doing all aspects of trauma. But first of all, we need a national policy. We can monitor the control program. We need rehabilitation. They can monitor hospital care and services. There must be a good communication network, which is not difficult today with so many methods of communication. They must have an ambulance service. We must train paramedics. We must teach children in school first aid. That should begin at school level. There must be adequate legislation. We should not only have legislation, but we must also implement the legislation. Then we must have trauma prevention programs. Technical guidance must be there. So these are aspects which a trauma control program can coordinate. Otherwise, there is no way of doing this. And we also know that prevention is better than cure. And that is another aspect which has to be initiated in Sri Lanka, because most of the accidents I showed you, trap gun injuries, winnowing fan injuries, most of them are preventable. But does anyone take any notice or educate the public on what should be done? Burns, another aspect. Now this I will show you one important aspect, another case report, just to show the value of prevention. Now this is another winnowing fan. a fan used by a farmer which is carried from one paddy field to another on his cycle, connected to a small motor. And this is his occupation. Take this fan from one paddy field to another during the harvest season and then winnow the paddy grain. And metal, like our bones, undergo fatigue fracture. You can see one blade has had a fatigue fracture and has been welded. There's a welding or plaster has been put, like treating fracture. One blade has been welded. That blade that came out has been welded. Now, where is this other blade? You can see another aspect. Another part of this blade is missing. Where is it? And this is, I am showing this just for the sake of showing that we can prevent diseases. If only that fan or that fan had a cover, a protective cover, this injury would not have occurred. These are things which people should know in our country. That is why I am showing this. This is a preventable accident. Now, when a patient like this comes to the hospital, from yesterday, today we heard about A, B, C, D, E of trauma. Now, when a patient like this comes to hospital, what do you do? We don't start with A. We forget A. I forgot A for the moment. I forgot B. And I didn't forget C. But C does not mean circulation. C means camera. So I went direct to my camera. Without circulation. Circulation was all right. He was living. So I went for my camera, took a good picture, which I am able to show today. And I have shown this picture not only in Sri Lanka, but in many parts of the world. And people are so upset when they see this. In one lecture, one person fainted in the audience. So these are preventable injuries. So remember to take your camera when you are treating trauma. So you can see how much it has gone in. It went in through the face just near the eye. Between the eye and the nose, cutting into the frontal fossa. But this man, is he living or dead? This is after operation. What is his occupation? Now, he is doing the same job. I tried to persuade him not to use that fan, but that is the only way he can live. So he has gone back to this machine, but he has not come to me again. This I told you, first aid, a very important and neglected field. We must start telling students in schools, first aid, how to stop bleeding. This soldier died in war because there was no one to stop bleeding from the small injury on the thigh. Here you can see trap gun injury I showed you. Completely disabled because of this preventable accident. So, my dear friends, trauma is a big problem in Sri Lanka. And we have to do a lot of things to counter this major problem in our country. So, we need health education. We need preventive programs. We have to help these victims who are disabled for life. We have to teach first aid. We must train paramedics, not only in Colombo but throughout the country. We need ambulance services with facilities to transfer patients to trauma services. And finally, we need rehabilitation of these victims who suffer the consequences of trauma. And for all that I told you, I cannot do anything, you cannot do anything. Combined, both of us cannot do anything. But we need a political will to change the system in our country. And this can be done only at the highest level, where there should be a national policy for trauma control. Without that, any of us trying will not succeed. I have tried many years. I have been opposed, but nothing has happened. So this is the only solution. But I hope those people there at the top will realize the importance of this problem in our country, because a lot of money is wasted by trying to treat these patients. which can be prevented. Thank you very much.
Thank you very much, sir, for that interesting presentation. I would like to invite Dr. Nihal De Silva to the stage. Dr. Gunatilaka, dear sir, thank you very much for coming these 2 days and sharing your knowledge and experiences with us. We really appreciate your contribution to BioInquirer 2014. Please accept a token of appreciation from IIHS. Thank you, sir. Next, I would like to invite Dr. Hernando Garzon to do his presentation on organizing accident and emergency for a disaster.
Thank you very much. And I've been asked to spend a little bit of time talking about how you can organize your accident and emergency department for a disaster. So we'll spend the next 45 minutes or so discussing that. And I think for most people in Sri Lanka, you probably don't need to be reminded of the importance of why we need to be better prepared or as prepared as we can be for disaster situations. Anyone who remembers, actually there's probably many people in the audience who were young enough and perhaps not by the coast that you may not remember or lived through the tsunami in 2004, 2005, but certainly that was a very big event that struck this country, and certainly with all the civil unrest that has occurred, there are areas of this country that have been under sort of chronic disasters too for some time. So I think everyone in this audience appreciates how this can affect communities and populations. I have for those of you who need a little more convincing, I have a 27-second video to show you that hopefully will frame the whole discussion we have for the next 45 minutes. And it's a video that was taken by a staff member from Doctors Without Borders in a Pakistani emergency department, a Pakistani hospital, when multiple trauma victims were brought to the hospital. And so I'll show you the video, and then we can go through and discuss it and discuss emergency preparedness or disaster preparedness. So for most of us who work in accident and emergency departments, that's not a normal day. For some it is, perhaps. But I think there are a number of things that I'd like to point out about that. And I think one of the things that's common in disasters, especially initially, is that there's a tremendous amount of chaos. Right? There's shouting, there's inadequate or inaccurate information. You don't know where things are, that kind of thing. And there's a lot of things we can do to try and bring order to that chaos. As a matter of fact, when I speak about emergency management and disaster response, I frequently say that the common theme of anything you do in a disaster situation is to try and bring order to the chaos little by little. And at the beginning, things are very crazy and chaotic, and as the response goes along, things come under a little bit better control. But you can see there are many things in that short video that illustrate the importance of adequate preparedness. There were victims on the floor in multiple rooms. There were all sorts of people in that video, and you don't know who is who. Who's the medical staff? Who are family and friends? We don't even know if these were combatants, and maybe some of the people are their allies, but maybe some of the people are in there were out to finish the job that they started if it was civil unrest. So there was no crowd control or security in the process, and there was no orderly way to manage these patients. So I'll go through that, and I'll come back to this video as we discuss some of the key points of preparedness. So the overview for this lecture I want to talk about here is, you see the accident and emergency preparedness is at the bottom of this list, because I think even though we'll spend most of our time focusing on those details of how you can do this in your accident and emergency department, there are several key concepts or larger issues that we should discuss first, so you're aware of the importance or the significance of the detailed plans you make in your department. First is to discuss the cycle of planning, mitigation, response, and recovery, and how that applies to the whole issue or the whole area of emergency management and disaster planning. Then I'll discuss some general concepts of emergency management and disaster planning. And those two things are actually the same thing. We used to use the term in the United States disaster preparedness, disaster planning, but we've more recently been using the term emergency management, because sometimes you'll get a surge of patients from a bus accident that isn't necessarily a full-fledged disaster, but it requires you to implement your emergency plan and surge up and get additional staff and open other ORs and call in other staff and those kinds of things. So but we actually all now are grouping that and discussing it as emergency management. So if I say emergency management, I also mean disaster preparedness. I'm talking about the same thing. And emergency management really happens not just in healthcare, not just at our individual hospitals, but it really should and can happen in every sector of society. Civic organizations, critical infrastructure things, right? Our power companies, our police and fire departments, our law enforcement needs to be involved with that kind of thing. Governmental organizations and entities, and it's an international process as well. And I'll go through that a little bit. Then I'll discuss more specifically healthcare emergency management, and then I'll finish talking about the issues in the accident and emergency department. So one of the first concepts that I would like to get across is this idea that we sort of live in a cycle in the disaster management process. And over on the right side of the slide, you see this event thing, and that's a disaster event. So when a disaster happens, we go into what's called a response mode. And that's when we activate all our emergency plans and put them in place to be able to respond adequately. And for most disasters, that's actually a short-lived period of time. That could be a couple hours, a few days, maybe a few weeks. The one exception might be something like a pandemic flu. Pandemic flus usually scale up gradually and can last for many months before they abate and slow down. But most other kinds of disasters, you have an immediate need to activate, and they can last, as I said, just for hours or days or even a few weeks, and that's a few weeks tends to be a long time in it, or a very big disaster. After the response phase, we move into recovery, mitigation, and preparation or preparedness. Recovery is the process of sort of cleaning up, restocking, doing definitive surgeries on people that initially had just stabilizing surgeries to get through the load of victims, those kinds of things. So the recovery process follows the response process, and it's not just in healthcare, right? In other sectors, that's when we rebuild houses and move people back to the communities that were affected by disasters. That's when power plants restore not just the electricity to the critical sites, but restore power to everything that had power before, those kinds of things. That's the recovery phase. After recovery, we also get involved with mitigation. And so mitigation is undertaking activities or programs that either decrease or prevent the problems we see in disasters. So, for example, in earthquake-prone countries or communities, we will build with different engineering codes that make buildings more resistant to earthquakes. We do that in California. They do that in Chile and Argentina, all around the world where there are enough resources to be able to do that. That's a mitigation activity, for example. One thing we've done in many hospitals in the United States that are in flood-prone areas, that after New Orleans and Louisiana, the area that we live, Sacramento, is the second most likely city to flood in the United States. And after our experience with Hurricane Katrina and the flooding in New Orleans and having to evacuate that city, we evaluated our healthcare system and its capacity to respond in Sacramento. And so one of the things that we've done is we moved all the emergency generators from ground level to a second level, or we've essentially built them up on stilts, because one of the things that happens in New Orleans is that all the hospitals were on emergency generator power because they'd lost the power from the utility company with the flooding, but then the hospitals flooded, their generators flooded because they were either on the first floor or in the basement, and now the hospitals were without power. So mitigation activity is learning from that lesson and putting your generators up in areas that are prone to flooding. That's examples of mitigation. And then the preparation phase is, as you'll see as we go through, is planning for what you're going to do in a disaster. What needs to get done? Do we need extra supplies? How are we going to get the additional staff to respond? If we need to evacuate the clinic or the facility or the hospital, how do we go about doing that? That's all the planning process. And so those are the four key stages in the cycle of disaster management or emergency management. There are a couple of points I'd like to make about that. If you look at this round circle, I'd actually like to shorten the response to just be a tiny little sliver. Because really, over time, the amount of time that we spend in the disaster response phase is really quite small. Disasters don't happen all that often, right? We really spend most of our time, what I'd like to do is enlarge this mitigation and preparation phase, because we spend most of our time in that phase, making the changes that we need to make us more resilient to disasters and preparing and planning to be in disasters. So that's one thing that is helpful to understand. The other one is I always teach that how we do during the response phase, how effective we are in responding to disasters, is totally determined by what we've done in the mitigation and preparation phase. Because if you get to the disaster point and you've done no planning and no preparation, of course it's not going to go well, like in that video. Chaos, who's in charge, where do we put these number of victims, that kind of thing. Whereas if you've planned and prepared and you've exercised your plan and you've trained all of your staff, then when the disaster happens, things proceed more orderly and you're able to deal with the problems that disasters give you. So what we do in preparation determines how effective our response is to disaster. So at the international level, there's a lot of attention to this, and there are a lot of resources. I just list a couple of them here. The Interagency Standing Committee is a multi-agency committee made up of the United Nations, the World Health Organization, and many others. And they produce a number of very helpful documents, including this one that's on the slide here. Preparedness saves time, money, and lives. As we just heard in the previous lecture, having a trauma care system will save lives, will decrease the cost to the community. Same thing with this. Adequate disaster preparedness will really save money and lives when the next disaster strikes. So the WHO, the World Health Organization, has many resources. The International Committee for the Red Cross does. And there are national guidelines. There are some that I've looked on the websites for the government agencies in Sri Lanka. There are some beginning policies around disaster preparedness that the government undertakes as well. So you have to understand that this emergency management occurs at an international level as well. The other important thing is that probably 10 to 15 years ago, the international model for emergency management was focused on the relief teams that came in from outside to help low-resource communities in poor countries deal with disasters. So they would focus on relief teams from richer countries, Japan, Europe, Canada, U.S., They would put resources into that. They would bring trained people from the United Nations. They would bring in the food supplies and relief supplies from outside. And what they've discovered is that's really not enough, that it takes time to get those resources into the country. It can take days just to see the first few teams, and it can take a week or more to get a full-scale international response into a country to help out. So really over the last 10 years, the WHO and the Red Cross and the UN have really focused on building the emergency management capacity of even low and middle income countries. Because there are, just like I spoke about yesterday, there are inexpensive changes that you can make to an EMS to create an EMS system. There are also inexpensive changes and things that can be done in low and middle income countries to make them more self-sufficient and better prepared to respond themselves. So for big disasters, we still need the international community to come in and help. But if you have local community and national preparedness, you're going to save lives and you're going to make a lot of difference from the moment the disaster strike until the additional assistance arrives from the international resources. So a couple more examples of what's available online. If you look up, if you search disaster management, emergency management on the International Red Cross site, the WHO website, you'll get all of this information. This information is really quite available and helpful. The one on the left is from the International Committee for the Red Cross. The one on the right is one of the many documents that's available on the World Health Organization website. So let me talk about some of the concepts in emergency management. And I think first and foremost, it's a complex process. And I'll just mention some of the words some of the key phrases that we talk about, some of the areas that work exists. And I'm discussing this emergency management, at least on this slide, at a national level or community level. And we'll discuss a little bit about how that goes into healthcare as well. So one of the first things that any community, country, health facility has to do is do some risk management or risk assessment, right? What are the things that we're most prone or vulnerable to? So here in Sri Lanka, you don't necessarily need to do a lot of earthquake planning, for example, or you don't need to do much planning for cold weather situations. You know, you're not going to have such a freeze that the water pipes break and flood. But there are many things that you can do around other kinds of disasters that you may be exposed to. There's other weather events, obviously, tsunamis, typhoons, other things that can affect this area. So your community, your health facility needs to do a risk assessment. In healthcare, we call that a hazard vulnerability assessment. What are the hazards that our healthcare system, our healthcare facility is vulnerable to, and how do we prepare for that? The other thing that's commonly discussed in emergency management is coordination. And again, as you've heard in many levels around trauma care, certainly also with disaster preparedness, coordination is very important because we don't work in a silo in a disaster. All different aspects of our community and society get involved. So for a healthcare facility, you have to coordinate with the pre-hospital care system. You have to coordinate with civic organizations. You have to know what the government response is. Where do I get information or communication about the disaster? Where is it safe to send patients and families after they've been treated? There's all sorts of interaction and coordination that needs to happen with other partners in the response. The other concept that's discussed in emergency management is the community resilience, as I mentioned. The better our communities are prepared to take care of themselves in disasters, the more people will survive and the more effective the whole response will be at the national level, at the community level, and at the local individual level and the healthcare level. Information management is important. How is information about an event distributed? How do we get information out about where people can go for food, water, or shelter, or medical resources when events happen? So what is the communication process that happens, and how is our healthcare system integrated into that? How can we get information about the number of victims that may be coming to us in an event, or how can we get information to the officials about what we're doing in the healthcare system and to get medications and supplies and additional personnel to help in the response? Or early warning systems are important for things like predictable natural disasters. So, like one of the reasons that the tsunami was so devastating is that many communities didn't know it was coming, even though the earthquake had happened sometimes hours before. and that the monitoring agencies in other parts of the world were concerned about a tsunami wave happened, but rural communities had no notification system to let them know something was on the way. So for something like a tsunami warning system, for example, or other weather events like hurricanes in the Atlantic or typhoons in the Pacific, if there's a warning system for communities, people can get notified, and the impact of that disaster will be less, at least in terms of the loss of human life. Resource mobilization. How do we stock up on items that we may need during disasters? And this isn't just in healthcare, for example. At a personal level, one of the things I teach and train in the United States is personal disaster preparedness. How do you stock up additional supplies of potable water and food for your family, for example, if you had to exist independently for 2 weeks? How do you prepare yourself and resource? How do you manage your resources at an individual level, at the place you work, in healthcare, for example, or in a community? And then the last thing frequently that's really important around emergency management is public education and training on all of these topics. And frequently that can happen through civic organizations. It can happen through schools. It can happen through the Red Cross. It can happen through Rotary Club. It can happen through many religious organizations and things like that. So let me talk a little bit about healthcare emergency management and these topics that I've been talking about that function at a national and international level. We can certainly apply also in healthcare. So first and foremost, whether you work in a small clinic facility or individual office, or whether you work in a large tertiary care medical center like this, you really need to designate a responsible person. Who is the person in charge at that facility for emergency management or disaster management activities? Because you need some accountability. If there's not a person in charge for this or responsible for this area, it tends to sort of sit and not get done. I think it's sort of human nature. One of the struggles we have in emergency management is people think, oh, it's not going to happen to us, or at least it's not going to happen to us today. There's more important things I have to do in my personal life or in my work life. This is something I can take care of later, kind of thing. And so very frequently, everywhere in the world, whether it's a developing nation or a poor nation, disaster management, disaster preparedness gets left to be done later on. So if you assign responsibility and appoint a leader for disaster management, that's one of the first steps that makes things progress and get things done more often. The next thing you have to do is really create a disaster preparedness committee, and we'll talk about the specifics of that. But again, because it is a multidisciplinary process, you need representation from different areas of your medical center. Even if you're in a small clinic, if you have a staff of 6 or 8 people and you run a clinic, it's really worthwhile to get everyone's input and create an emergency response plan or disaster plan for your small clinic. How are you going to get people into work? How are you going to notify them that something's happened? If maybe you decide to close down your clinic and then your staff can go help in the hospital or some other nearby facility. So even a small clinic will benefit from having some type of disaster plan. Once you get that team together, then you can go about the activities of doing the hazard vulnerability assessment. And once you have that, you can make your disaster plan, or as we call it in the United States, an emergency operation plan, an EOP. And then the last important thing about this whole process in healthcare is actually practicing your plan and doing disaster drills. Talk about that. So as far as the committee is concerned, again, because it's multidisciplinary, you really need representation from different areas. You need not just the medical expertise from the emergency or accident and emergency department, but also the surgeons, the nursing staff, the security staff, radiology, blood bank, basically any system in your hospital that is affected or has to do some work in a disaster response should have some representation in the disaster committee. In the United States, it's a requirement of any hospital, but we have a joint commission which approves and certifies hospitals and does reviews every 2 to 3 years. And they always look at the emergency management process at every hospital. You have to appoint a leader. You have to have a committee. They look at the minutes of the meetings. Most committees meet at least quarterly. Many of them meet monthly. So if you're doing this work on a regular basis, you can move your plans forward. As far as the hazard vulnerability assessment, again, emergency managers are used to doing this. There are existing tools for how you can do this. There's templates, there's questionnaires that you fill out so you can identify what are the likely hazards in your area. Are you in an agricultural area? Are you in an industrial area? Are you susceptible to chemical spills? Are you in an earthquake area? All these things that help you determine what your hazards are for your particular facility. Once you've determined those, and we actually revisit those every year in hospitals in the U.S. Because things can change, obviously, or other events happen that show us, oh no, we're actually more vulnerable for this kind of thing than for that kind of thing. So those can adjust year to year, but in general they stay the same. And then you take those HVAs, those assessments, and then you build your emergency operation plan based on that. But you also build your emergency plan, and the common phrase, and this is used internationally as well, is to have an all hazards approach. So even though we may have really detailed plans for earthquake response in California, for example, or wildland fires, we have a lot of those in California as well, that we also have this all hazards approach that in case we get a train derailment or a terrorist event or those kinds of other things, we can also be prepared for whatever kind of disaster or emergency comes along. So let me talk a little bit about the emergency operation plan for healthcare for any facility. It's really a playbook or a guide for how you operate in a disaster. So it's the kind of thing that once you prepare the plan, it becomes a guidebook for what you're going to do during a disaster. The important thing to do is to keep revisiting that plan and training on that plan, because what I've seen happen is once it's done, you pat yourself on the back about the great job you did, and then you put it on the shelf and it gathers dust. And 2 years go by and the disaster comes along and people are like in that video where there's chaos, they don't know what they're doing. Someone says, I think we have an emergency plan, where is it? It takes them 20 minutes to find it and pull it off the shelf. And by that time, they're going through it saying, I'm not really familiar with what's in here. It's been 2 years since I looked at this. So it's important to not only create a plan, but also to have it be a living, breathing plan that you exercise and look at and review and edit along the way. For a small clinic, you may just have one emergency operation plan that addresses all the important things for you to do. For a large facility like this, a big hospital, you want probably a main facility plan, but the key departments probably need their own plan that's complementary. So the accident and emergency department may have its own plan that's specific to operations there. The operating theater, the surgery department may have their own kind of plan that addresses the issues that they're going to face in a disaster and so on. Usually you organize this by sections, and I'll go through the sections. I think the screen here is gone, but I think I can go on with what's on the screen here. And one of the other key features of emergency operation plans is to have job action sheets for each position. So job action sheet is literally a 1 or 2 page piece of paper, and for every key position in your emergency operation plan, it has exactly what you need to do, so that if someone is assigned to say you're going to be the leader of the triage unit, and that nurse or that doctor isn't familiar with the job or hasn't done it in a couple of months, that job action sheet is really a bullet point of what they're responsible for and what they need to accomplish in that role. So it could be very helpful when the disaster strikes to pull out these job action sheets and give them to the people that are in each position. And the other thing that can be in your emergency operations plan, or should be, are protocols or procedures to follow in certain ways, and we'll discuss what some of those can be. So key elements of your emergency operation plan. One is a patient circuit. So following the patient from admission to discharge, exactly where is that patient going to go? How are they going to get treated? Very often this could be the same way it is in your day-to-day clinical practice, but often it's not. So, for example, when you get a surge of patients and there's too many patients to be taken care of in the usual accident and emergency department, you may devote another area, an office, a cafeteria, a waiting room, to deliver patient care as well. So you may decide to take the less injured patients and create a unit in the cafeteria, for example, and have them evaluated there. So that's why it's important to create a patient circuit for the emergency operation plan, so you can adapt to all of those ways that your disaster response is different from your day-to-day operations. You should also have an area about human resources. What's the organizational chart for the structure? Who's going to run the alternate care area? Who's going to run triage? Who's in charge of the whole response? It may be the head of the hospital. It may not be. Or what if that head of the hospital was away when the disaster struck? Who's going to fill in that leadership position? Those kinds of things. The human resources should also include a call list. How do we get our employees who are off shift and call them up and ask them to come into work if necessary, if you need additional staffing, that kind of thing. Procedures and tools for case management, standard protocols that are clear and specific, forms, if you're going to use disaster triage tags, I'll talk about that, other patient care forms if they differ from the way you operate normally. You have to address logistical issues in your emergency operations plan, specific materials for each department, how you're going to resupply the supplies that you're using, those kinds of things. Infection hygiene, we call infection control in the United States. It's important to address that through this whole plan. Where you're going to get food and water for your staff if they're going to stay long hours and you're going to feed them while they're working. All these things need to be addressed. Coordination and how that happens, not just within your system internally, but also externally. You need to define, again, those partnerships and how you're going to coordinate with pre-hospital care, with the suppliers, your medical suppliers who might bring in food for the hospital staff and patients, those kinds of things. Also, you need to address security. As you saw in that video, it's really very important to control your entrances, both for safety and security of the staff, but also for the patient's sake. If you have a room crowded like that with people, how are you going to be able to deliver care? So being able to post a sentry, it may be common practice under normal conditions to allow all the family members in an exam room with a patient, but when you have so many patients and so much crowding, you really have to create different rules around that. Normally we allow one family member in with a patient, but if things are very busy in our emergency departments, we actually have all family members and friends wait out in the waiting room. So creating security to make that plan is important. Psychosocial support for family members, patients, and staff, how you're going to make that happen. And then once you have your plan, as I said before, you need to practice your plan and make sure it's an effective plan. I always teach having a plan is not the same as being able to implement it successfully. And I'll give a couple of stories that illustrate that point that are examples of this. This picture is an aerial picture from my response to New Orleans for Hurricane Katrina. Hurricane Katrina hit the United States 8 months after the tsunami affected this area, and it was in August of 2005. And it was such a strong hurricane. The winds weren't so strong, but the surge from the sea was quite strong. And New Orleans is a city in the United States which actually exists mostly below sea level. And over the years, they've built up levees to protect it against the seawalls and against the canals and things like that that drain into the sea. And what happened is with the storm surge that came in with the hurricane, it broke those levees and the city flooded. So there was some damage, wind damage from the hurricane. It took out power and everything. But the biggest problem is that the city, within about 8 hours, flooded. And it's the first time in U.S. history that we had to evacuate a city of 500,000 people. So every citizen had to leave the city. So these buses were the buses that were intended. The city of New Orleans has a fair amount of poverty, and so over half the citizens don't have their own car, their own vehicle, their own way to get out of the city. So the plan for the city included these school buses. School buses in the U.S. are yellow, and these were the buses that were intended to take the citizens of New Orleans out of New Orleans in case the city had to be evacuated. The problem with that plan was they never identified drivers for these buses. So when the need to evacuate the city came along, everyone was clearing out. They had nobody who could or would drive these buses, and they essentially sat unused. And all of the people that couldn't get out of the city had to gather in football stadium, and it was a terrible mess, and it took days to get everybody out adequately. And so I bring this up because that's an example of the city had a plan to evacuate people, but they never tested the plan. They never realized there was a flaw in the plan. And so as good as you may be at having all your committee members sit together and create a plan, and you don't really know if it's going to work until you test it. Another example also came out of the event in New Orleans. Memorial Hospital, all the hospitals in New Orleans that got flooded had to evacuate. And one of them was Memorial Hospital. And in their HVA, in their hazard vulnerability assessment, they determined that flooding was one of their top 3 risks, right? So they knew that flooding was a potential problem. Their plan to evacuate the hospital had plans to take people out by ground vehicle, by trucks and vans and buses and ambulances. So, in retrospect, that doesn't make a lot of sense, because if one of your risks is flooding, how are you going to drive people away if your place is now flooded? And so what ended up happening at Memorial is that they were not able to evacuate before the flooding came, because it came very quickly. Now they have a need to evacuate, and their plan doesn't work, because they're going to do it by ground, and there was no way to do it by ground. So they also had to wait 6 days before they finally had enough help from outside, people in boats, helicopters, other things to help evacuate the victims. So without testing your plan, it could just be a lot of wasted paper sitting on a shelf. It could not be an effective plan. So that's one of the key reasons that we need to test our emergency operations plan and do disaster drills. Another one of the requirements from Joint Commission to get accreditation of hospitals in the U.S. is that every hospital has to do at a minimum of 2 disaster drills every year. And so we'll test something different every time. Okay. So let me go on to talk about the disaster plan for the accident and emergency department specifically. And we'll go through this talking mostly about the chain of casualty care and how that has to happen. This is a picture from my response to the post-election violence in Kenya in 2008. So really the chain of casualty care is the path followed by casualty from the point of injury all the way to specialized care as the condition may dictate. And these are the key areas: the pre-hospital care, what happens in the accident emergency department, and then what happens through the hospitalization and to a specialty center if needed. And again, your plan should include all of that. We'll focus on the accident and emergency care department. This is the clinic area that we built up I did a response with Doctors Without Borders to Kenya during the post-election violence in 2008, and we created a trauma clinic next to one of the slums where most of the violence was happening. And the local ambulance system essentially stopped functioning because the feuding tribes were not really respectful of the EMS system. So even if you were a health worker, an ambulance worker, if you were from the opposing tribe, they would pull you out of the ambulance, beat you up, and set fire to the ambulance. So the local EMS system stopped working. The MSF staff had to start using our vehicle to go out and get patients and bring them to the clinic. And this was the clinic that we set up where we would do trauma care, and then anyone who needed a higher resource than we were able to do, we could drive or ship to the area hospitals to take care of it. And so again, patient circuit became important in developing the whole flow. So this is an example of another Doctors Without Borders patient circuit in an emergency department that was set up in Iraq. And the point to illustrate here is that you really have a map of your facility, and you see where do patients come in, where do I set the security guard to control access to the department. You can see on the top right there's a resuscitation room. A little below that is the waiting room. And then different areas of this accident and emergency department are designated for different triage levels, and I'll go through the triage levels in a minute. The red and the yellow are the most immediate. The black are the expected to die, and the green are the less injured. So we created areas of different places that you send patients, and that helps you organize how you deliver care in your emergency department. So again, part of the patient circuit, the patient arrives to the hospital, and the first step that happens is triage. And depending on the different triage levels, different things happen to the patients. They go to different places. So the patient circuit has to consider triage. the stabilization and initial care, moving forward if they need surgery or hospitalization is needed, and then ultimately discharge of that patient, how that happens to another facility for additional care or home once you've delivered definitive treatment. These statistics are from the Red Cross, and in a war situation or trauma situation, civil unrest, if you took 100 victims, approximately 75% are in that green category. They have injuries that need attention, but they can wait for some time. They're not immediate. About 20% are usually lethally wounded and will likely die, and about 5% need emergency care. So when you get all these patients all at once, the really key things about dealing with this effectively, saving the most lives, is you want to detect that 5% that need emergency care right away and get that care to them as quickly as you can. And then you want to take the other 75% that need treatment and give them the correct treatment in a timely manner and deal with it effectively. So when you get those 20 victims from the bus accident, or 40 victims from two buses colliding together, or 100 victims in a war situation, all of this begins with triage, and to classify the wounded according to simple criteria, and then you can categorize them and who needs the care most efficiently. Triage, as you probably know, it's a French word. The whole concept of triage came from the Napoleonic Wars, when a war surgeon realized that he was getting too many wounded to take care of them all in sequence. So he developed the concept of prioritizing the most immediate first. So general priorities, obviously, respect the triage system, follow it. It will help you identify the sickest. It will help you save the most lives. In that chaos of the video where you saw when the initial victims come in, there are non-medical priorities too, which includes the crowd control, the security, the infection control. All that needs to be in your policies and your plans. So in disaster situations, the triage is different or should be different than the normal triage that we may do in everyday life in accident and emergency. Because even in a busy day in accident and emergency, maybe you get an average of one patient every 5 or 10 minutes. You can have a nurse or two at two different triage stations. You can take 15 minutes to do vital signs, to prioritize that patient that way. But in a disaster situation, you literally may get 20 patients at once or 40 patients at once. And so you can't take 15 minutes to triage one patient at a time, because by the time you get to the 48th or 49th victim, it's 4 hours later and you're still triaging. So disaster triage has to happen more quickly, and there are several ways to do that. So the idea of disaster triage is to really rapidly evaluate everybody in 1 or 2 minutes. You deliver minimal treatment, not necessarily just no treatment. You do just basically life-saving interventions, and you move on to the next person you categorize. So there are several systems of disaster triage. This is one of them that has come out more recently, and this was created by a panel of 50 experts internationally, and it's called SALT, Mass Casualty Triage. SALT stands for sort, assess, L is for life-saving intervention, and T is for treatment. So first you sort, then you assess, you deliver quick life-saving interventions for those who need it, and then the fourth you get to definitive treatment. So I want to walk you through it just so you get a sense of what this could be like when you work in an accident and emergency department. So the first step is sorting. And paramedics and firefighters do this all the time when they come on scene of a multi-car accident or a bus accident or something. But sometimes you'll get 2 vans of victims unloaded and no one's done anything yet, and you have to do that in accident emergency. So the first thing you do to do global sorting is you just speak up and say, anyone who can walk, get up and go over here. So right away, you've sorted a group of patients who are conscious enough to be able to process instructions and follow commands, and they're well enough to get up and walk. So they at least have a blood pressure of 90, right? So you've sorted right there or the least acute. So those are the people that you're going to look at last. And then let's say you had a group of 50 people, and 30 of them got up and came over here. So you have 20 that are still lying on the ground, like in that video that you saw. And then you say, well, if you didn't walk over there, who can wave to me? Show me that you can hear me. And then of the 20 that are there, say 10 or 15 kind of wave to you or say something to you. You say they're signs of life, right? Maybe they didn't get up because they have a broken leg. or something. So you don't know exactly why they haven't walked over, but at least they're responding to you. So those people have some kind of sign of life. They've heard you say, wave at me, they've responded. And then the third group of people are those that are still and haven't moved. Maybe you even wonder if they're alive. So you've just, in about 30 seconds, done a global sorting of 40 people, right? Those that can walk and move and listen, those that are showing signs of life and waving at you, and the 5 or so that aren't moving at all. So now you start to assess them individually, and you start with the group that didn't move at all, because they're likely going to be the most sickest. So that's the step 2. Then you assess them, and you walk over to those people that aren't moving, and you do that quick ABC again, right? So, and that's when you also implement life-saving interventions. So you look if they're breathing, you check if they have a pulse, do they have any obvious injuries, and that's when you can take 30 seconds to do these top 3 life-saving interventions. You probably can't read them in the back of the room, but you see that cross, that black cross there says LSI, life-saving interventions. 1, control major hemorrhage. 2, open an airway for someone that's not breathing. And 3, do a chest decompression for someone who might have signs of a tension pneumothorax. Those are the 3 life-saving interventions you can do quickly before you move on to the next person. And that alone might save a life right there. So if you have somebody who's on the ground, who's obviously has an arterial hemorrhage, start wrapping that up. Put pressure on it, get an aid or something like that. Controlling hemorrhage. Remember, as we've talked about since yesterday, controlling hemorrhage is the number 1 preventable cause of death after an injury. So if you can start controlling major hemorrhage, you've done something for that person. You assort him to an area, these colors that I'll talk about, and then you move on to the next patient. For someone who's not breathing, again, maybe they're hypotensive and falling unconscious, and maybe it's just their tongue has obstructed their airway. So can you reposition them quickly, try and do a chin lift, open their airway. If they start breathing, that person has signs of life. He can be triaged to an immediate category, a red category, but before you move on to someone else, and then he needs to get seen right away. If that person is not breathing, they're done. In this setting where you have 50 people and you're trying to save the most lives possible, you probably don't have the resources, the ventilator, you would have to spend 2 or 3 or 4 people on intubating that person who's showing no signs of life. And meanwhile, you may have several people with arterial hemorrhages who you could save, and now you won't get to them because you're spending so many resources on that one person. So in a true disaster situation, if someone's not breathing on their own, they get categorized to the black category. So then you move on. If they're breathing on their own, then you go over to that next big box. Are they obeying commands and have purposeful movements? Do they have a peripheral pulse? Are they in respiratory distress? Is the major bleeding controlled? So if you go no on any of those, you'll go to either an immediate category or an expectant category. And as you look down there, it says likely to survive given current resources. So for example, let's say you have someone with evisceration of abdominal contents, like in the last lecture we saw somebody who came in like that. Let's say what came in was 6 or 8 victims, and you're in this teaching hospital, right? So 6 or 8 victims is not terrible for a facility this size. How many doctors and nurses do we have working in this facility? So that person with the eviscerated abdomen, we can probably take care of all of those 6 or prioritize them. That person with the eviscerated abdomen would go into an immediate category. And it would be an appropriate triage decision to devote the resources, get the trauma surgeon, prepare the OT, and get that person up for definitive care. If you have the same 6 or 8 victims delivered to a small rural hospital that has a general practitioner, no surgeon, and the anesthesiologist is 2 hours away, there's a small OT, and you have this same victim who has an eviscerated abdomen, but you have other people, say, with orthopedic trauma or other kinds of things that you can also save their life. It may be that in that situation, the person with the eviscerated abdomen may move to an expectant category. Maybe you hope that you can get other resources, transfer him to another facility, call a surgeon and anesthesiologist. Maybe they can get in more quickly than the 2 hours. But with the resources you have available at that moment, you're probably not going to be able to save that person. That person would be categorized to a black category, if that makes sense. So given current resources, you can triage patients to different categories. Okay? And then going back up to the big box with those questions, if they don't have any of those things, then they can move over and they can go to a delayed or a minimal category and get seen later. So just to present briefly to you, the concept of disaster triage is different than the way you triage on a day-to-day basis in your hospital or clinic system. And I just went through it briefly in about 5 minutes. That's not enough time to make you experts on this. And if you get involved with disaster drills or plans, this is something that potentially should be practiced. As a matter of fact, this is actually one of the disaster drills that we run at our hospitals many times. We say today's drill is just on triage. And we actually we moulage victims. We get students, medical students, student nurses many times, and they become our victims. And they each get a little card about who they are and what their trauma is and how they should respond to the student who's surveying them. And so then we'll put them in a room, and sometimes we'll put fake blood, or we'll splint a limb for someone who came in with a fracture, those kinds of things. And we have our students practice this. So everything I told you, we set them in the room, and they start sorting. And certain of the victims know they're supposed to go over and stand. So they're not really traumatized. They're moulage victims. And they go through that practice. Because the only way to get good at doing this is by practicing it. And our firefighters and paramedics are very good at doing this because they already do this in the field in their regular practice every day, as I said, when they come across motor vehicle accidents and things like that. But healthcare people are rarely good at doing this because they don't practice it. In most situations, we don't have to move to a disaster triage mode. And so this is a good thing to drill on and get good at for the staff in the accident and emergency department. Okay, so again, highlights about triage. You should classify according to simple criteria. It gives you a vital prognosis for the patient and what category they go into. It can quickly identify who needs to go to the operating theater and who needs to go more quickly than someone else. The basic categories here are the reds are the good chance of survival if you have immediate interventions and treatment. Yellows, intervention required, but less urgent than the red group. The green patients are the ones that need some intervention, but they can wait up to hours. I mean, someone who has a laceration that needs to be repaired, but it's not arterial bleeding, it doesn't compromise neurologic structures or joints, that can get cleaned up, that can wait hours to get evaluated. And then the last category is the black category or gray category in some areas, and those are it's too late to save those lives, and they need some comfort care. So types of things that we see that we triage into each category. A red category would be something like moderate to severe respiratory distress, acute hemorrhagic shock, abdominal or thoracic wounds with abnormal vital signs, incomplete amputations or vascular wounds with ischemia to the limb distally, burns, second and third degree burns, more than 15 to 40% of body surface area. A yellow category is slightly less urgent than the red. Those would be things like stable abdominal wounds without signs of shock, wounds with tissue loss requiring debridement, maxillofacial wounds without respiratory distress or difficulty, fractures and vascular wounds without ischemia, and wounds to the vertebral column with or without paralysis. The green category are the minor wounds, burns to less than 15% body surface area, sprains, other kinds of minor injuries, psychological trauma. And then the black category are the seriously wounded that have a slim to no chance of survival with your current resources at the time, depending on the facility you are. Examples are major body surface area burns, unconscious cranial trauma, CNS trauma. This is an example of a triage tag. So remember the disaster triage process I told you. How do you document or pass along or leave a record of what you've done in that 30 seconds or 60 seconds that you were by that patient? So each patient gets a card. You can have a nurse or scribe, someone follow you, or more junior staff member that can fill in some of the key information here. You can see the big R, which is the triage category. It tells everyone who comes after you that person has already been triaged and what their category is. There are many versions of this. You just need to create one and exercise with it and decide what kinds of information go into it. So let me talk a little bit about the process now. In about 15 minutes, 10 minutes, 12 minutes, I've started to triage my 40 victims, right? And the other staff here are now, they came in, and everyone that's red and yellow, someone might be directing the greens to go to some back room, cafeteria, we'll get to you soon. The other clinical staff are grabbing the reds and yellows and moving them into the treatment areas where the reds and the yellows are going to get seen, and staff are dedicated to starting treatment on those as you finish triaging your 40 victims. And so additional staff are then taking care of people in the red treatment area. So this is where the organizational chart may be of value, right, or is of value, but that I may have the role that day to do the disaster triage. Dr. Leonard may be assigned to take care of the red treatment area. Dr. Nihal may be assigned to take care of the yellow treatment area. So everyone has a role, and you go, same thing. You divide up your nursing staff that way. You divide up all the technicians and the help that way. So the kinds of things that we do for the red and yellow patients, again, this is the same thing that we discussed yesterday. You go through the A, B, C, D, E, don't forget your camera, of trauma care and ATLS. And you re-examine these patients from head to toe. You give them IVs as necessary. Antibiotics per your protocols. Many have open wounds or contaminated, infected. Antibiotics should be part of a protocol with that. Your surgeons should be involved with creating the trauma care protocols that happen even in accident and emergency, obviously. So you may need to give them antibiotics. You may need to update tetanus status, appropriate labs and x-rays as are indicated by your primary and secondary review, those kinds of things. Be careful. Don't suture. Many wound injuries are contaminated, have devitalized tissues. You need good input about what to stitch and what to close and what can wait for definitive closure. Immobilize and splint fractures, especially if they're not going to get treatment right away. You don't want to. It helps alleviate pain. You don't want to worsen a fracture. You don't want to create vascular compromise by leaving a fractured limb unsplinted. Put patients in position of comfort. Check the patient's status over and over. And patients can get recategorized and retreated. Someone that was in the yellow category and didn't seem that bad initially can fall into worse respiratory distress and maybe needs to get moved up to the red category, for example. Or you can have somebody with a deformed ankle fracture and no dorsal pedal or tibial pulses, and he has ischemia to the foot, and he's in a red category, and then the clinician might quickly, say, grab the sides of the bed and just pull on the ankle, improve the deformity. It's still a broken ankle, but now it's anatomically aligned, and your pulse is returned. That patient can drop from a red category to a yellow category. You splint the ankle, and he can get his surgical repair of that broken ankle later on. So you can recategorize people as the need arises. So the types of things that are surgical priorities in this would be thoracic trauma with respiratory distress, maxillofacial wounds with respiratory distress, significant external hemorrhage, especially if you're still having difficulty controlling it, penetrating abdominal trauma, especially from high-velocity injuries. You need to explore all gunshots and penetrating trauma from explosions. Not all stab wounds may need to be explored. The surgeon should make that call. Unstable, non-penetrating injuries, also surgical priority. Lesions of the limbs with amputation or vascular compromise distally, and burns from 30 to 50%. Okay, some issues about care for patients that are in the green category, the less injured patient. Obviously, that person still needs a head-to-toe exam. Sometimes you'll find a concerning injury that wasn't apparent because they look well. Monitor vital signs, give tetanus, appropriate labs and x-ray, the same kind of thing, and treat wounds, minor wounds and burns. On this slide, I have the fill in the patient's file or medical record. I didn't say that for the others, but in addition to the triage tag, it is really important, especially if you are reminded of the chaos you saw in that first video, very important that you have a patient record of treatments, evaluations, interventions. It could be the chart you normally use if you find it's effective in this kind of setting. You may want a specific one-page document that has room for the orders, nursing notes, physician notes as well, something that can stay with the patient so that future care teams as you move them to different locations in the facility or in the hospital, we'll know exactly what was done. So maintaining documentation is very important in disasters. It's something that when you see the chaos of that video, it's something that we as healthcare providers tend to leave behind or forget in disasters, but it's very helpful for the patient care and future medical care that stuff get documented. So just because someone's been categorized to a black category, an expected category, expected to die, doesn't mean that we ignore them or neglect them or the family. These people may still be alive. They may have devastating brain injury, but they're still breathing. But they're still alive, and we still need to treat them and their families humanely. It's very important to give them adequate analgesia, and it's very important to provide psychological support. If you have clergy, if you have social workers, if you have psychology, psychiatry staff, they should come in and help care, certainly for these patients and these family members. So a couple of general points. All patients, even the minor ones, have been victims of a traumatic experience and need care, and especially psychosocial care. And don't forget to treat pain. So a couple of things that don't pertain to accident and emergency, but as if we work in accident and emergency, we're going to be moving patients along into the operating theater or hospitalizing them for further care, and we need to be aware of some of the things that are important in that setting. The quality of primary surgery really determines the final result. So our surgeons should not be quick or sloppy. They need to be efficient. They need to stabilize, but they really need to do quality primary surgery from the beginning. Intervention priorities have to be constantly reviewed. So again, if someone deteriorates, their triage category needs to get changed, or the other way around. If someone improves and stabilizes, they can get moved to a less acute category. Hospitalization, we need to have particular attention to the postoperative care, nutrition, psychosocial support, and physiotherapy as needed by patients. The psychological support, again, I can't say how important it is to do this from the very beginning, and not just for the family and for the victims, but also for the staff. And it's important also to not wait until the event is fully over, because frequently these events are traumatic not just for the patients and the staff, but it's very difficult for us as caring people and healthcare workers to see the devastation and the suffering that goes on. And so to have psychosocial support when available for our staff members is very important as well. So a couple of points before I wrap up to talk about the discharge from the emergency department, and that could be either discharge to home or discharge to the hospital or another referral center. If you were able to provide definitive care, then that patient can be discharged home, assuming that the environment is safe to do so. In civil unrest situations, sometimes hospitals become places that patients and families seek shelter from further danger. And so that actually should be and could be in an emergency operation plan for a facility. Where do we accommodate patients and family members that can't go home? If the patient needs specific care that you don't have, you need to refer to another facility. So it's important to assess what are the capabilities of your facility. This medical center, for example, is a tertiary referral center. Their plan about transfer and referrals has to include who are the community hospitals and clinics who are going to be sending us patients here, and how do we prepare for that. Whereas at those smaller clinics or hospitals, you have to say, well, we don't have a neurosurgeon, so if we have someone with a treatable neurosurgical case, where are we going to send them? Do we have an agreement in place with that hospital? We don't have dialysis here. We have patients with renal failure. Where are we going to send people for dialysis? What medical center? Those kinds of things. So in advance, in your emergency operation plan, identify the kinds of services you can't provide and identify where you're going to do that in advance. So when the need comes in a disaster, you have those agreements in place. You can pick up the phone and place the call, and that will improve the likelihood that you'll be able to effectively transfer somebody for definitive care. So the referral criteria depend on a number of things. Obviously, as I mentioned, the specific need of the patient and also the stability for transfer. So you may have someone that needs neurosurgical care, but they're so unstable because they're about to herniate that they're likely not going to survive the transport. So maybe that patient should just be treated expectantly at your facility as opposed to transferred. So someone needs to be stable enough to survive the transfer. You shouldn't just send them because you can't take care of them. What's the availability of specialty care, and can those facilities take them? Because maybe in a very big disaster, this hospital may be overwhelmed as well. And so you need to establish that call first and say, can you handle this patient? I need to send you. That's part of what the agreement is and how the communication should happen between facilities. It's also important to have the appropriate referral documentation, send the important medical record and the assessment and treatment that you did at your facility so that the receiving facility has that information to help them in patient care. And then whenever you can, after everything is over in the recovery phase, it would be wonderful to do follow-up on the patients you referred and the patients you treated and sent home. So in summary, I want to mention the things that I've discussed here. The first summary is be aware of the cycle of response after an event and how brief it is, and how we spend most of our time in recovery, mitigation, and preparedness. And how effectively we are in our response phase is totally determined by how good the work was and how much work we did in the preparation phase and the mitigation phase. Emergency management is a complex process. It operates at an international level, national level, local communities, healthcare facilities, and even at an individual level. I frequently train the first part of disaster preparedness is personal preparedness. What's your plan? How are you going to take care of your family so you can go to work, if you have something? How are you going to identify where your family is so you're not so worried about them, you feel like you have to leave work to go help them? If you have a personal plan, that's very important. Then you can participate in whatever's going on at your work site, or clinic, hospital, that kind of thing. So emergency management, complex, and it's at all levels of society and all critical infrastructure industries, not just healthcare. Healthcare emergency management, identify a leader, have a committee, a disaster committee with involvement from all the relevant stakeholders, all the players involved. Make a plan, a disaster plan or an emergency operation plan. Practice that plan. You have to make sure it will be an effective plan that when you implement it will actually work. And disaster drills are very important, not just to guarantee the validity of your plan, but also to train your staff. And then specifically in the accident and emergency department, define the patient circuit. You do a disaster triage, and then through ATLS, ABCD, treatment care, stabilization, definitive care, follow your treatment protocols, make sure you provide psychological support for patients, family, and staff. Thank you very much. Any questions? I failed yesterday, actually, after my lecture to ask, and I should have. And does anybody have questions about this or what I spoke about yesterday? Thank you.
Thank you, Dr. Gazan. I would like to invite Dr. Nihal to the stage. Dr. Gazan, thank you very much for coming down to Sri Lanka to be part of the research conference, and thank you very much for all your contribution. Please accept a token of appreciation from IIHS. Thank you, sir. So let's have the lunch break and come back to the auditorium at 1:30. Thank you.